Excellency, Executive Governor Benue State is about to take his leave. We have the interest of masses of He is the people's oriented governor. He is the masses governor. He is the amiable and narrow and social governor. That is why the good people of Benue, I am proud of him, celebrating him wherever he goes. That's why the infrastructure development of revolution of the Benue State is blessing by the common man in the street. Your Excellency, I appreciate you.
On ground, and other dignitaries are also yet on ground. We need to give them the warm entertainment they deserve for this event.
before we finally settle down again after a little break of His Excellency says it. Fiona, are you ready? Please.
Check 1, 2.
Benue born, talented, wonderful and powerful artist packaged for our latest entertainment who are here. It's about time you entertained us. Very
while
quickly.
that is happening, please may we return to our seats so we can make enough room for the next entertainment we are about to
Check 1,
be
2.
treated to.
2.
Please, Fiona, are you ready? If Fiona is ready.
If she is ready, I'm sure she has a microphone there.
Come
She
forward.
can respond.
If she is not ready, Eugenia the Great, come forward. If Eugenia the Great is not ready, Flexibility Queen, please, it's about time we have you entertain us here.
Ladies and gentlemen, please let's take our seats. The fact that the governor has exited does not mean that this event is over. As a matter of fact,
Fiona is ready. Please, Fiona, take the stage very quickly.
Thank you, sir. Thank you. DJ. DJ, my song, sorry. Thank you so much for having me here. DJ, are you ready? I greet our Father,
2. Check 1, 2.
His Royal Highness, His Royal Majesty, sorry.
2.
DJ. Fiona, Kwangwere Moga first.
2.
is the DJ experiencing an identity crisis? There are two artists who are built to perform, so you need to have lined up the appropriate one. It's Fiona who is built to perform, and then Eugenia, not the other way around.
Fiona Aga, Fifi's Empire. Loving you was not the problem. Keeping you was. Nobody did know when you're ready or not. Save me from the stories where you did preach. How you want to change your ways. How you want to change my life. Already I know that your type of guy will never be my type. Yet I made you comfortable. I gave you a part of me. I did this, I did that for you. The one time I asked for a favor, so I tell him. Oh yeah, move on, so I tell him. Oh yeah, move on, so I tell him. Oh yeah, move on, so I tell him. Oh yeah, move on.
Aye, one don't was the one. Into what's the gama yanka me batelega. Mpu welongam kabekai suwega. Udon so was the one. Mpu wikoboga. Mbe ya kai kobo. Mba kusungwe. Kwada zanyo. Mba kuhowe. Yamba kwaga. Bauko sumo. Wakile. He gonna bring humba hypo. Mma fofo. Baka fonko. Mongo aje. Ajo bako. Tana mufanga yaga mome suwako. Beda bakirim keba mome koshu. Shechu. Nando wampa kumashu. Was it do? Was it? Sheku we she. Himba himba shu. Baby me no shu. Balu she.
So I tell you. Oh yeah, move on, so I tell you. Daddy, I know that your type of guy will never be my type. Yet I made you comfortable. I gave you part of me. I did this, I did that for you. The one time I asked for a favor to attend. Oh yeah, more to attend. Oh yeah, more to attend.
Thank you.
Thank you so very much, Fiona, for that wonderful song. And right after Fiona, ladies and gentlemen, our next act for the day, Eugenia the Great. Eugenia.
Eugenia the Great is expected to take the stage at this point in time. Please, Eugenia the Great. After which, Rastafilas, and of course, flexibility. 1 minute or 2 minutes, please.
All right, DJ, let's go.
Eugenius the Great, Lalakusa Matanga, the pride child of Africa, Mkenana, Shimai Benue. Pasala kuje, alama kura santa, mezala yana hamu, kule muna, uyengi shebe, Mama Afrika, muna Olona ngumeza Soweto Afrika India payameza Hello manawe Tumburukumawe Urukutu yasema Kwa muhando se Afrika Joyankule nede habe Amaya kausi bineke Masala kuje Africa yekufero aho mana hoso kibeke bitana kwa bashenya kwetei oya kuti monga haja aya kutu monga haja Mezala yana hamu Kule muna Yoyangi chebe Buntu
munaye olonongo meza Soweto
Masala kuje
indi ya panyameza
Masala kuje Masala kuje
Everybody should sing this song today. We are happy because of what is coming to Benue. Today we are happy and proud of this present administration. Cheer! Okay now, if you know how to sing this song, this is the time. Let's sing the song together. Yeah man. Cha cha. Huh.
Many will sing that she will say, many now. Doshima, Doshima, Doshima,
Cheer! Cha 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 cha. Put up! Cha lu 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 lu. Let's Benue must be great again. China. Yeah.
Doshima, 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 Kubensiyen, me akwa kutonga, me akwa kushiwe, shiyende, libanunzeo. Doshima.
DJ, thank you very much. I want to salute my boss, Dr. Paul Botwebo, HEON. Thank you very much, sir. Thank you, sir.
Thank you so much for the performance.
Adule, this was
I
the
thought
man
you were
that
South
bought
Africans.
a car for me for the first time in my history of entertainment. Thank you.
Wonderful contribution out there from Eugenia the Great. Eugenia the Great, we appreciate you. Yes, thank you for exercising gratitude for the gesture that was once extended to you by former NAFDAC boss. Distinguished invited guests, ladies and gentlemen, my co-MC, what is next?
Thank you so very much. And so we continue with our presentations on today's theme towards the attaining of a one-stop hospital for the treatment and control of cancer among our people. And would like to make this very important point, that the treatment of any disease, no matter how little no matter how minor, no matter how severe, cannot be effective except if the proliferation of counterfeit drugs in our medical system is controlled. Therefore, ladies and gentlemen, it is my pleasure now to call to the stand the man who was once saddled with this responsibility of controlling the proliferation of counterfeit drugs into our health system. And he did a fantastic job of that. And if we are being effectively treated against diseases, then we have to be grateful to none other than the former Director General of the National Agency for Food and Drug Administration and Control, Dr. Paul Botwev Ohi. He is going to be our next speaker for today. Let's put our hands together for Dr. Ohi.
Standing before us is Dr. Paul Botwev Ohi, who is an exceptional individual with an extensive background in law and medicine. He's a physician, a pharmacologist, a biomedical scientist, he's a litigation support specialist, an attorney and counselor at law, a medical expert witness, a consultant on anti-counterfeiting and brand protection. He is the founder of Ohi Law Firm, PLLC, Houston, Texas, USA. Dr. Paul Ohi is born on the 9th of May, 1960, at Mbabiendi in Oshongu local government area of Benue State. He has a very robust educational background that I may not be able to read it all within this ample time. Dr. Paul Ohi attended the local government LGEA primary school at Gay, Bagua, let's say 1967 to 1973. St. Francis College, Otukpo, 1975 to 1980. He studied medicine at University of Jos, then later won a scholarship to study medicine in Russia, and graduated with honors from Tripple State Medical Institute in 1989. He studied at Health Science Center, University of Texas, San Antonio, Texas, and was called to the Texas Bar in 2007. He was a clerk at High Court of Justice in Makurdi, Benue State. He worked under Justice Sylvester Omaru, James Ogebe, and Katsina Aru, our former Chief Justice of Nigeria. He was a lecturer with University of Jos in Plateau State. He worked as a biomedical scientist, University of Texas, between 1993 to 2003. Was a director, National Gold International Consortium in Texas, 2007. As we know, he is a former Director General, National Agency for Food, Drug Administration and Control, that is NAFDAC, between 2009 2016. Was a Vice Chairman, International Medical Product Anti-Counterfeiting Task Force, Geneva. He pioneered chair steering committee on WHO membership mechanism on spurious, substandard, falsely labeled, falsified counterfeit medical product. Why have NAFDAC embarked on an inspiring campaign to clean up fake industries? He is known for his work in regulatory excellence and has received numerous awards. I may not be mentioned how because the time is not who may not allow me to do that. Dr. Po Ohi has authored and co-authored several scientific publications. He is happily married to Eugenia Ohi and is blessed with children. Can we clap our hand to this wonderful man?
Good afternoon, very distinguished ladies and gentlemen. I want to first and foremost sincerely thank the leadership of the Benue State University Teaching Hospital, led by Dr. Hwande, for their vision in starting a one-stop cancer center for Benue State. And not only doing that, but convening this first ever of its kind summit in Benue State. And also, not stopping at that, inviting me to come and talk about counterfeit medicines. As you heard here this morning, no matter the kind of hospital you start, if you are not aware of the menace of counterfeit medicines, you are working in vain. So inviting me at this very start to come and discuss counterfeit medicines, I think is a big step forward. And I want to assure you that we assist, use all my knowledge, use all my national and international connections to work for this cancer center to make sure that it succeeds. So, thank you very much. I'm here to talk about from the shadows to the spotlight, unmasking the menace of counterfeit and substandard medicines and the role of guardians of health in stemming the tide. So I'll just go straight to the presentation. We keep saying counterfeit medicines, counterfeit medicines. What is counterfeit medicines? I've been going around the world talking about counterfeit medicines. I've been invited to different countries. If you go to India and you say counterfeit medicines, you have lost them. They don't believe in the name being called counterfeit medicines. They call it spurious medicines. If you go to the US, if you go to European Union, you talk about counterfeit medicines, they understand it. But if you go to Brazil, for example, and talk about counterfeit medicines, they will not accept it. They call it falsified medicines. So this continued for a very long time until we convened at the WHO. As it was mentioned here, I was the pioneer chairman of the WHO membership mechanism made up of 193 countries to discuss the issue of counterfeit medicines and to define what counterfeit medicines are. It took us many years, so we came to a conclusion, we came to a unified definition that everybody would be happy with. And then we decided, at the WHO we said, we call it spurious, substandard, falsely labeled, falsified counterfeit medical products. It's a very complicated name. But for the purpose of this presentation, I will just be mentioning the counterfeit medicines. I'm not going to bother you with all those other things. And so at the WHO, we consider counterfeit medicines to be fake or falsified medicines that are mislabeled. Medicines that are mislabeled deliberately and fraudulently, craftily, regarding their identity and or source. A medicine that somebody, you cannot blunder into manufacturing counterfeit medicines. You have to sit down and deliberately and fraudulently mislabel that medicine to deceive the consumer that it is what it is not. So counterfeiting of medicines is a criminal offense because it's a specific intent offense that you sit down to manufacture something that is mislabeled to deceive the consumer into believing that it is actually what is not. So all kinds of medicines have been counterfeited, both branded and generics. So a counterfeit medicine is made by someone other than the one who has authorization to manufacture the medicine. They just copy somebody else's medicines and begin to promote it as if it is the owner of the medicine. Let me quickly distinguish substandard medicine. A substandard medicine is a medicine that is manufactured by the authorized manufacturer, but simply does not meet the standard. Either higher active pharmaceutical ingredients or lower than nature needed pharmaceutical ingredients. And because that kind of medicine is ineffective against disease, it can even be harmful. So somebody who actually is authorized to manufacture counterfeit medicines, to manufacture medicines, actually produces something that does not meet the standard. Either because their GMP is not up to level, GMP is good manufacturing practices, it's not up to the level that is required, or maybe their equipment is not that, maybe their staff are not that knowledgeable. So they manufacture that falls short of the required standard. I give you an example. The manufacturers of my Peking teething mixture that killed many Nigerian children was a substandard medicine. They were authorized to manufacture that medicine, but they produced something that ended up killing Nigerian children. It is dangerous, but it's not a criminal offense. It's in tort law, that is a negligence case, not a criminal offense, because there was no intention to manufacture something that will kill the children. So I just told you about some of the differences between the counterfeit medicine and substandard medicines. But which medicines are the most often counterfeited? Any medicine can be counterfeited, like I say, both branded and generic. However, from our experience, we have observed that counterfeiters, they target medicines that are with high volume of use for treatment of diseases or public health interest. For example, the anti-malaria drugs, the antibiotic drugs, the antihypertensive drugs, the anti-diabetic drugs, and of course, lifestyle drugs. Most of them, people are shy to go to a pharmacy and buy the lifestyle drugs, so they order them through the internet. In advanced countries like Europe, Canada, and the US and Canada, most of these counterfeit medicines come from those ones that are ordered through the internet, because somebody is too shy to order them. How do you identify counterfeit and substandard medicines? I can tell you counterfeit medicine, but when you see them, how are you supposed to know that this is what I've been talking about? There are a number of indicators that should make you suspect that a medical product might be counterfeit or substandard. Although these indicators that I'm going to talk here will not always be present with every counterfeit. We advise patients and healthcare professionals to look out for example, you see suspicious packaging. This medicine, the packaging is even suspicious. Maybe it has been tampered with. Or maybe it's mislabeled. The labeling, the spelling errors. The spelling of the medicine may be incorrect. Maybe the spelling of the active ingredients or even the address of the manufacturer may be incorrect. Then you know that you are dealing with a counterfeit medicine here. The medicine can have different shapes, unusual appearance or color or sizes. If you have been taking the medicine before you go to buy and you find out that this one does not look like the one that I am used to. It has different shape. That's a counterfeit. Or the medicine may have unusual colors and odors or taste. Then there are sometimes low prices of medicine, too low, too good to be true. If the price is unusually low and too good to be true, then usually we are dealing with a counterfeit medical product. But it is important to know that the absence of these signs does not mean the medication is authentic. With the recent sophistication in printing technology, it has become almost impossible for even the most sophisticated pharmaceutical security expert to just identify a counterfeit medicine job by looking at it. You just imagine, if somebody can print the printing now, you can copy something even with the minute details on a capsule. So what stops you from copying the packages, the packaging, or what stops you from copying the spelling correctly? So today, in a side-by-side comparison, it can be extremely difficult to tell the difference between a counterfeit and real medicine. It really takes laboratory testing to confirm 100% if a drug is counterfeit. But at NAFDAC, during my tenure, we came up with different ways of identifying counterfeit medicines. That is when NAFDAC gained international recognition in the use of cutting-edge technologies to fight substandard falsified medicines and other unwholesome regulated products. Some of these technologies include the TrueScan, the mini lab, and the mobile authentication service. The TruScan is a handheld device used for on-the-spot detection of counterfeit medicines. It allows regulators and law enforcement agents to conduct field-based screening of pharmaceutical samples to quickly and accurately identify counterfeits. For example, we could be in Boko today, right now. In the next hour, it's a handheld device. We can go to Boko in a shop and immediately test the medicines. Within an hour, we determine which of them are counterfeit inside that shop. And then before you know that we're in Boko, we're in Utukpo the next 2 hours, testing medicine. Before you know that we're in Utukpo and Boko, we're in Nasarawa State or somewhere else. That same day, we can test medicines in different shops across the country. In fact, when we started this, the celebrated investigative journalist, Dr. Torbide, we know very well, Dan Rada, with CBS, came from the US here to come and watch us live. We went to the shop, to the market itself together, and we were using the TruScan to identify the medicines. And he was there live to capture it because it was initially he couldn't believe that there was technology. We were the first in the world to use that technology, the TruScan, to go into the market and check the menace of counterfeit medicines. Then the mini lab, as the name implies, is a small lab, a mobile laboratory that you can use it to test counterfeit medicines. The mobile authentication service is what most of you here are familiar with. You go into a medicine store, you see a medicine, especially the most often counterfeited, we require that each of them must have this technology on it. You see an antibiotic and anti-malaria drug, you take it, you will look at it and you see something like a scratch card on it. You scratch that, see a PIN number, you feed that into your phone and text a short code, and within less than a minute, you get an answer whether the medicine is genuine or is fake. And you make the decision whether to buy that medicine or to report it to NAFDAC. Using that technology, we were able to put the power of detection of counterfeit medicines in the hands of more than 80 million Nigerians who had cell phones. Anybody who walked into a cell phone was suspicious as a NAFDAC informant. Anybody who walked into a cell phone, 80 million Nigerians who can go into a pharmacy store with a cell phone in hand, the pharmacist knows that this person is a potential NAFDAC informant. He can scratch, text, and if he finds the medicines to be counterfeit, he will report to NAFDAC. This helped us to dramatically reduce the incidence of counterfeit medicines in Nigeria. But we didn't stop there. We upgraded NAFDAC laboratories, 4 of them, 1 in Agulu, 1 in Kaduna, 2 in Lagos, 1 in Oshodi, 1 in Yaba, we got international accreditation for these laboratories to be able to test medicine to confirm, like I say, 100% that these are counterfeit. So, what is the impact of counterfeit medicines on the cancer center that we're about to start? What can be the impact? Fake medicines can do a lot of damage to any healthcare setting. They pose a serious public health hazard and waste consumer income worldwide, but most especially underdeveloped and economically disadvantaged countries, where the already poor consumer is made to pay for products that have little or no medicinal value. Somebody is very poor, and he gathers money. Sometimes he has to beg some other people for this money to buy medicines, and then he ends up buying a fake medicine. Somebody has diabetes. His sugar level is very high. The hospital has identified that this man has high sugar level. We need to immediately reduce the sugar level, and yet he buys a counterfeit medicine. They are administering no result, and he continues his journey to death. So that's the kind of damage that counterfeit medicine can do. Counterfeit antibiotic and anti-malaria drugs can lead to treatment failures with dire consequences, sometimes including even death. In some cases, medicines of compromised quality create resistant strains of the microorganisms that are no longer treatable with even the most effective and potent medicines. And this poses a grave danger to our low healthcare budgets and our already weak and highly compromised healthcare delivery system. Some other potential health risks associated with counterfeit medicines include the ineffective treatment, counterfeit medicines may not contain the active ingredients needed to treat your condition, leading to ineffective treatment or worsening of your health situation. Your doctor has identified, has diagnosed your condition and prescribed the right medication. He gives you that medicine and it is not working. He observes that your condition continues to worsen. He may even end up increasing the dosage, still no effect. He begins to doubt his laboratory results, whether it was the correct laboratory result that helped him to achieve a diagnosis. Then he begins subsequently to doubt his own skills, diagnosis skills. So these are some of the dangers. And counterfeit medicines can, what is it? Okay. So counterfeit medicines sometimes may contain harmful ingredients. If you go and see some of these counterfeit medicines where they are manufactured, you will know that this is not a place that should manufacture anything that somebody should put into their mouth. They put anything inside those medicines. So there are long-term health consequences. Taking counterfeit medicines can lead to long-term health problems, such as organ damage or increased risk of chronic diseases. There are also public health implications of counterfeit medicines. That's increased hospital admissions, prolonged stay in the hospital because they are not working, and treatment failures and death. And all this leads to increased cost of controlling the disease, increased out-of-pocket expenses, increased human suffering, loss of confidence in the healthcare system. You go to this hospital, they diagnose you, they prescribe the medicines, you scrape the money that you can find and buy the medicines. They didn't work. Your condition continues. Then you go to another hospital. The doctors also prescribe the medicines, it doesn't work. After some time, you don't believe in the healthcare system. You don't want to go close to any healthcare facility. You start looking for traditional healers who may help you. So that kind of patient has lost faith, has lost confidence in the healthcare system. There's also increased burden on the healthcare system. So the recent scourge of counterfeit medicines have made it increasingly difficult for states to ensure that the scarce resources available for healthcare are judiciously used in procuring only the right quality of medicines and medicinal products. So what is the current situation of counterfeit medicines globally and in Nigeria? The volume of counterfeit medicines circulating in international trade, looking for weak areas where they can penetrate and enter the system. You know, there was a recent crackdown on illicit narcotic trade. People like Escobar. So most of the drug barons have now diverted their resources into manufacturing counterfeit medicines and distributed them globally. The business of counterfeiting has become very more globalized, more militarized, very dangerous, and even more sophisticated. So counterfeit medicines have been on a steady increase recently, especially in developing countries with weak regulatory capacities. In 2010, worldwide sales of counterfeit medicines, according to WHO estimates, were in excess of $75 billion. But if you go with some other organizations, including the World Customs Organization, the annual market value of counterfeit medicines was as high as $200 billion. With sales ranging from, that's European Union estimate, with the sales ranging from about 150 billion to 200 billion euros annually. Counterfeit pharmaceuticals are the most lucrative sector of the global trade in illegal copied goods. According to an estimate from the WHO on 11th of December 2023, that's just last year, Counterfeiting life-saving medicines is a lucrative criminal enterprise that forms part of a $413 billion worldwide fraud. It has been estimated that up to 15% of all drugs sold are fake. And in parts of Africa and Asia, this figure exceeds 50%. In Nigeria, doctors were frustrated. Like I said, they will be treating the patient, no response. Until in 2001, NAFDAC, in collaboration with the World Health Organization and Department of International Development, revealed that they did a test around the country, a survey around the country of medicines, and they revealed that more than two-thirds of medicines in Nigeria were substandard or falsified, with basic medicines like antibiotics and anti-malaria being the most affected. By 2005, the number of counterfeit medicines had decreased. With the effort of NAFDAC, they reduced the incidence of counterfeit medicines by 2005 to just about 16.7%. Between 2010, like I said, when we introduced the TruScan and all these other technologies, monitoring of antibiotics, anti-malarials, and anti-diabetics that are easily falsified was done using this TruScan. From that, from the total number of 5,790 that were tested, 6.4 failed. It means that counterfeit medicines were reducing by 2012. In 2015, another study on anti-malarials was conducted as round 1 by NAFDAC in collaboration with National Malaria Elimination Program, National Supply Chain Management Program, and United States Pharmacopoeia revealed that counterfeit medicines in Nigeria have reduced to about 3.6%. And they continued, if you look at subsequent studies, they continue to reduce progressively to less than 2%. Unfortunately, tackling counterfeit medicine is like a balloon filled with water. If you push it this side, it budges on the other side, and you take your hand, it bounces back, sometimes even stronger. So, unfortunately, by 2019, NAFDAC reported that the prevalence of substandard falsified medicines in Nigeria had gone up to 16.7%. As part of the continuous monitoring of quality of medicines, NAFDAC did a study on quality of oxytocin injection. I know that oxytocin is very important in stopping postpartum hemorrhage. And they found out that about 74% of the oxytocin tested failed quality standards, mostly because of poor storage facilities. So as a result of the high failure rate, NAFDAC implemented regulatory actions that included mopping up of the poorly stored oxytocin from distribution chains, strict monitoring of storage and transportation facilities, and heightened awareness to the sensitivity of the drug to high temperatures. The agency also collaborated with United States Pharmacopoeia to provide technical support to Juhe Pharmaceutical, a company that is located in Anambra State, in Oka, Anambra State, to manufacture good quality oxytocin for use in Nigeria. So there are some other factors that can compound spread of counterfeit medicines. And this includes the high cost of medicines, cost of medicines going up, ignorance of the consumer. I did a simple study. I took 2 drugs and went to a consumer, a patient, and told him that one of this other drug I'm holding in the left hand is a fake one, but I can sell it to you for 2,000 naira. On the other hand, I say, well, this one is a good one, but it's 5,000 naira. The consumer said, give me the fake one. And this is not one instance. Out of 10 people, you get about 6 people because of the poverty and the lack of knowledge about the counterfeit medicines. Now, so you think that your drug is counterfeit. So what are you going to do? What next are you going to do? You have discovered that you might have taken a counterfeit medicine. If you suspect that you might have taken a counterfeit medicine or have concerns, consult your healthcare provider or report it to NAFDAC, which has offices in every state headquarters and other relevant authorities. So what is NAFDAC going to do to curb the menace of counterfeit substandard medicines. To combat this, NAFDAC has adopted the WHO rapid alert system for surveillance and monitoring of substandard and falsified medical products in the bid to rid Nigeria of such products. We have what we call pharmacovigilance. We encourage doctors and healthcare professionals to report adverse drug reactions to the pharmacovigilance department of NAFDAC, who will now take care of it. During my tenure at NAFDAC, I also started another branch, another department, which we call the so we have done a lot of, it is therefore important to conduct public awareness campaigns, sustain public enlightenment, understanding that counterfeit of medical products thrives in ignorance. NAFDAC is employing many avenues to enlighten the public of counterfeit and substandard medical products. Some of the efforts include sensitization and awareness programs. NAFDAC and Your Health on TV, the NAFDAC number, we had it on radio, FRCA, the NAFDAC Consumer Safety Club, the NAFDAC NYSC, and then consultative fora with stakeholders, interagency, interprofessional collaboration, and community efforts. The collaboration with sister agencies such as Pharmacists Council of Nigeria, Pharmaceutical Society of Nigeria, Nigerian Association of Patent and Proprietary Medicines, and so many others. We work with religious organizations, traditional rulers, other community-based organizations, and concerned citizens. Our post-market surveillance directorate that I started when I was at NAFDAC, what they do is they go and announce to the pharmacy stores and quickly test the medicines that we have approved to be in the stores to see what the consumer is buying. They buy it, take it back to the NAFDAC laboratory and test those medicines for their quality. So these all have helped to reduce counterfeit medicines in Nigeria. Then we are talking about law reform. Because of NAFDAC advocacy, in China now, it is death penalty. In India, it is lifetime jail. Paradoxically, here in Nigeria, which is at the most victim at the actual receiving end of counterfeit medicines, the penalty is paradoxically the most lenient. It is only 3-year jail term, a maximum of 3-year jail term currently, and sometimes only a few months in jail, sometimes even just a small fine. So during my tenure at NAFDAC, I proposed a bill to the National Assembly. And in that bill, we were looking for, personally, I wanted death penalty, just like in China. But then I formed a committee to advise, and many of them were people, civil rights activists, who believed that death penalty is no longer fashionable globally. So we came to a compromise that in Nigeria also should be lifetime jail term like in India. And in situations where the counterfeit product approximately cause the death or bodily injury of the victim, the assets of the counterfeiter, the convicted counterfeiter should be used to compensate the victims. Because we know that at the heart of counterfeiting lies the huge incentive to make huge financial gains. So if you take that incentive away, they will be less likely inclined to engage in counterfeiting. So now I come to the role of guardians of health in stemming the tide. As guardians of health, we need to ensure access to quality medical products, source medicine from legitimate sources, ensure rational use of medicines, ensure pharmacovigilance. Pharmacovigilance, I already talked about, report adverse drug actions to the appropriate authorities so that they can take action. Report if you see counterfeit medicine, report to NAFDAC also, which has a pharmacovigilance department so that they can take appropriate action. Report treatment failures and adverse drug reactions. In conclusion, in our effort to establish a one-stop hospital, like we are trying to do here, and we are going to achieve it by the grace of God, Because I can see the enthusiasm. We must be aware of the menace of counterfeit medical products and substandard medical products and take appropriate measures to prevent their entry into the system, while building systems that enable early detection with a view to forestalling the harmful effects of these products. Thank you, and I'll be willing to answer your questions. All right, thank you.
Thank you very much, Dr. Paul Ohi, former Director General, National Agency for Food and Drug Administration and Control. So that was the first part of that presentation on the menace of fake or counterfeit drugs, and the second and concluding part of it will now be done by a pharmacist, a consultant, drug production and quality control. He's the MD CEO, Vincal Pharmaceutical Industries, pharmacist Idoko Emmanuel Otobo. Pharmacist Otobo, thank you very much. Let's put our hands together for Pharmacist Otobo for the final part of the aversion of fake drugs. Another round of applause, please.
Thank you very much. I want to stand on the existing protocol. I am very, very delighted to co-present with my boss, Dr. Paul Ohi. I am the MD CEO of Vincal Pharmaceutical Industry. We are the first and only drug manufacturing industry here in Benue State. And this was made possible by my boss, Dr. Paul Ohi. He has brought this industry to Benue State. So I am presenting on averting the menace of fake drugs. Issue of fake drugs cannot be emphasized. Whatever effort we put in putting it across to the public will never be too much. So I will do everything possible not to repeat whatever he has already told us for the want of time. The following are ways to avert counterfeiting among others. We cannot be able to exhaust them because of the time factor. Number one, claiming the ownership of the drug. As he said earlier, even as professionals, the technology is improving, and so when counterfeit drugs are brought before the professionals, they will not be able to identify it. Talk more of people that are not professionals. And so one of the ways you can avert counterfeiting is to take ownership of the drug. How do you do that? By establishing pharmaceutical industry in your environment. There you can be able to hold the company responsible for whatever you see with the drugs. And that helps you to avert counterfeiting. The manufacturing industry is right here in your place. And so whenever you discover issues with the drug, you can easily channel it to the right place for appropriate actions. And then if you have pharmaceutical industry in any vicinity, it scares the fakers, because the only way you can identify and be sure that this is actually a fake drug is through laboratory tests. That can confirm that this is actually a fake drug. And so the individual that is selling this drug to you can be held responsible. Every pharmaceutical industry has the capacity to test and confirm that this drug you are carrying is a fake drug. Vincal Pharmaceutical Industry has that laboratory. So it's a plus to Benue State. When this is done, the fakers are afraid to send fake drug to such environment because it can be identified. We now have machines that can test and tell you the exact quantity of active ingredients in any given drugs that you are taking. So a situation where you are suspecting any drug, please make it available to Vincal Pharmaceutical. Then the second point here is partnering with pharmaceutical industries. This is very important that our able CMD is here with us. It is not correct to bring drugs to an institution like this from open market. You partner with the pharmaceutical industries so that you can get drug directly from the companies that manufacture them. With that, you are sure of the source and you are sure of the quality of the product you are buying. Then government policies and political will. Government policy and political will is very important in averting fake and substandard products. For instance, there's what we call drug management agency in every state that can be established by the state, which good enough our talk and do governor has approved that of Benue State, where drugs can be procured directly from the companies and then redistribute to all government institutions. This will go a long way reducing menace of counterfeit products. Then we also, Oga has talked so much about education, so I will not talk on that much again. But another area that I'll quickly talk on before I leave the stage is that counterfeiting is like a game. As the hunter learn how to shoot without missing, the birds are also learning how to fly without perching. The new method of counterfeiting now, you cannot even find anything that Maoga has put across to you in terms of the pack. Now, when drug expires, the counterfeiters, the money mongers, go from one pharmacy to another to mop them up. And then when they take it to their place, if you look at any time you buy drug, when you look at it very well, the ink that print the expired date is coded. It's not printed along with the packs, because we print the packs and keep in quantity. The day you are manufacturing is the day you code the manufacturing date, the batch number, and the expiring date. So that ink is not very strong because it is coded. They have discovered that. So when drug expires, they go around and mop them, put their hand in a chemical and neatly clean it from it, and then recode it and give it a new shelf life. By the time you buy such products, you can never identify it as a fake because it's carrying all the attributes of genuine drug. And unfortunately again, when drug expires, it still elicits the pharmacological action that is intended for that drug, because it is only a minute part of it that has undergone degradation into a dangerous chemical. We said it is not good for use again Because when you use it, as minute as it is, it becomes dangerous to your organs, the kidney, the liver, the heart. Unfortunately, this action we are talking about, this negative action we are talking about is insidious. When you take it, you will not see the action immediately. It takes about 5 to 10 years for it to begin to manifest. And so it becomes very difficult to trace it back to the drug you have taken. That is the danger of counterfeit drug. And when they do that, they sell it very cheap because the source is very, very cheap. You go to NAFDAC today, you hardly see pharmaceutical or pharmacy premises returning their expired drug to NAFDAC as it's supposed to be. Where are they going to? They are returning back to the market. And when they return back to the market, it comes back to you again. Anybody that is buying such products, the product becomes extremely cheap. Unfortunately, we are poor people here. And so we keep looking for where drugs are cheap so that we can get them. And by the time you buy these drugs, if it is a painkiller, you take it, your pain is gone. And so if anybody tells you that that drug is fake, you always argue it, but it works. But the danger is living in you. So where drugs are sold extremely cheap, please run away. Something is happening there. We have premises where people that sell drugs cheaper than the manufacturer. What do you think is the magic? There is no magic. This is what is happening there. Thank you very much.
Let's put our hands together more befitting for that wonderful presentation. Distinguished invited guests, ladies and gentlemen, and before I give room for the next presentation to be taken, may I very quickly recognize and I miss the presence of the pioneer surgery, head of surgery department, Benue State University, Big Daddy, Professor Barnabas Ike. We respect your presence. I'd like to also respect the presence of Professor Priscilla Dene Aka, Professor of Plastic Surgery, Benue State University Teaching Hospital. May I also respect the presence of my father himself, former HOD, Political Science Department, Benue State University, and of course, a renowned academia, a renowned scholar, a seasoned Democrat, Professor Daka David Utume. Please, a round of applause for him. May I also warmly celebrate the First Lady, wife of the Capacity CMD Benue State University Teaching Hospital, Mrs. Edo Teunwahwande. A round of applause for her. At this point, distinguished invited guests, ladies and gentlemen, would like to entertain a presentation by Dr. Samuel Tene. And of course, the person to take his citation is Dr. Teka Bito, consultant public health physician, Benue State University Teaching Hospital. Please, both of you can come up. A round of applause for them.
Let me add that Dr. Otene is a consultant radiation and clinical oncologist, the cancer specialist. His citation as he takes the stand.
All protocols very respectfully observed. Dr. Samuel Anaja Otene, FMCR, actually the only radiation and clinical oncologist in the entire Benue State, also of Benue State origin. Thank you very much. Well deserved to our consultant radiation and clinical oncologist. Dr. Samuel Anaja Otene is a radiation and clinical oncologist with almost 2 decades of experience in Nigerian cancer space. He's 50 years old and obtained his medical degree at the great Ahmadu Bello University, Zaria. He acquired a postgraduate fellowship in radiation and clinical oncology of the National Postgraduate Medical College of Nigeria in May 2012. He's still the first and until today the only Benue State indigene with that qualification. and very important for our cancer center, which the endowment fund was done today. He was the chief consultant and head of oncology and palliative care department at the Federal Medical Center Makurdi for almost a decade before switching to the academia about 3 years ago. He is now a senior lecturer at the Federal University of Health Sciences, Otukpo, Fusho. He remains a visiting consultant to the Benue State University Teaching Hospital, Makurdi, and the Federal Medical Center, Makurdi. Until recently, he was the lead oncologist at Asi Ukpo Comprehensive Cancer Center, Calabar, Cross River State, actively helping to set up what is now the only fully functional radiotherapy center in the south-south region of Nigeria. We trust that that capacity will come to bear for our cancer center as well. He is a member of the Ministerial Technical Working Group on Cancer, as well as a life member of the Nigerian Cancer Society, the premier cancer society in the country. He has served on the board of management of the Benue State University Teaching Hospital in the past, and is a past national president of the Hospice and Palliative Care Association of Nigeria, HPCAN. He is a past chairman of the Nigerian Medical Association, Benue State branch. And until recently, was also the chairman of the NMA's Cancer Committee at the national level. And he performed extremely well and was recognized as the best committee in the entire past biennium by the president of the NMA. He has won multiple awards both at the state, national, and international levels. Dr. Samuel Anaja Otene is married, is a family man, a great husband, and father to 6 children. Please join me in a rousing welcome to actually appreciate this very thoroughbred consultant, radiation and clinical oncologist, a teacher par excellence, medical doctor par excellence, and he will also be sharing his wonderful thoughts on demystifying and domesticating an ultramodern cancer care center through gameful collaboration. Sir, you're welcome.
Thank you very much, Dr. Bito. Good afternoon, ladies and gentlemen. Please just permit me to recognize my chief medical director and stand on other existing protocols already established. I see so many of my trainers, my teachers seated. If I start calling your names one by one, we will not finish, Professor Isegbe and co. But I really appreciate you, and I have to say this because as medical doctors, we always have to appreciate those on whose shoulders we stood or we are standing to see what we are seeing right now. I will try as much as possible not to talk very plenty. If we can finish what I have to say in another 15 minutes, I think it will be great. Now, I can try to do that because up to 70% of what I would have wanted to say of the things that were on my slides have already been said by Dr. Adewale when he was here. And I am so happy he was able to say that to the hearing directly of my governor, His Excellency. So I believe that having heard all of that, the things I have to say now would be filter some of them and quickly get to a conclusion. I wish we could project my slides, but I think I'm beginning to realize that that might not be possible. So as to save our time, I'll just proceed. I just really wished we could have done that because Professor Audu Oyemocho spent over 2 hours with me this morning trying to ensure that my slides were beautiful enough for the audience to see and appreciate. I'm saying this now as an acknowledgement to the wonderful work he has done, and to also tell my younger colleagues that it's always important to have your mentors near you. You can never know everything, and you always run to them to get things better done. So quickly, I am supposed to actually talk about domesticating a cancer care center in Benue State, and the objectives are actually simple. I just want to give us an idea of the cancer burden in our environment, and then we talk about what an ultra-modern cancer care center actually is. By the time we've done all of that, I think the rest of the job is done. And Thankfully, Dr. Adewale actually did a wonderful job of talking about the cancer burden in Nigeria. You can easily extrapolate that into the cancer burden of Benue State. See, when somebody dies, I think I must just say this because it's important. When somebody dies, normally we say, let's observe 1 minute's silence. In truth, practically, if we take that 1 minute silence as the 60 seconds that 1 minute is worth, within that 60 seconds that we are standing, between 16 to 19 other human beings across the world would have died of cancer. Cancer alone. That's how bad the situation we are talking about is. As in, 9.7 million people die annually from cancer. Over 18 million people get this disease, new diagnoses on an annual basis. It is that bad. And the worst thing is that this figure is only a tip of the iceberg. It's expected to double within the next 20 years. And even that doubling is only a tip of the iceberg. He had mentioned earlier, and I want to reiterate it, that we have about that was the 2020 figure. 124,815 people were diagnosed with cancer in the year 2020. Those figures, like I keep mentioning, are only a tip of the iceberg. But you see, because we have 37 states, I'm adding Abuja as one of them, and some are large, some are small if you want to take an average. It's difficult to get the exact figures of cancer within a state such as ours, Benue. But if you just take 24,000 plus and divide by 37, you are going to get over 3,000. Somewhere 3,300 and something thereabout. In essence, we are saying that not less than 3,000 people on an annual basis are likely to be diagnosed with cancer within Benue State alone. You know, that is every year, and it is huge. You see, the issue with the cancer is the fact that it is no respecter of sex. Men, women, it is no respecter of wealth. The wealthy, the poor, and I keep saying some of the things, I will just say them and move on. I keep mentioning wherever I have the opportunity to speak that virtually every Nigerian family is only one cancer away from penury. And that is it. I think it's just the essence of this lecture for me right now is to emphasize some of those salient things, and then I move on and sit down. What do I mean by one cancer away from penury? As you see lots of us moving around with our Tokumbo cars, looking very flashy, wearing beautiful traditional attires and suits. One cancer in the family can liquidate all the wealth of that family down to the ground. Just 3 days ago, I was speaking to somebody who is my sister. She's a cousin and was diagnosed with breast cancer here. But she lives in Lagos. She was diagnosed here in Makurdi. But because she lives in Lagos, I told her, look, go to Lagos and go to Luth. Go to Luth. I repeated it over and over. I will call my friends that are in Luth and tell them my sister is coming. She said, brother, I hear you. That was in January, February. Then she called me just a few days ago. She went home, and because she felt better, she did a CT scan, and it showed that there was no pulmonary metastasis. She felt better, so she went home. She didn't do anything until June, July, when the lesion got much worse. The reason I'm mentioning her right now is that she called me 3 days ago crying on the phone. Why? Instead of even going to the Luth, which is a government PPP initiative, she went to one of the private centers in Lagos that has a radiotherapy facility. I won't mention the name, but there are only 2 private centers in Lagos, so it's easy to find. And she was given a bill of how much her treatment will cost. Guess what? 62 million naira from start to finish. So she was calling me to lament about the cost, and I kept saying, I know why I asked you to go to Luth. You are the one that carried yourself to the place where you have gone to. But I am mentioning this to give us an idea of the cancer burden and the cost of care. 62 million naira. She wanted to say, what are they doing? I said, look, there are targeted therapies that I can give you for breast cancer. Each dose costs 2, 3, 4 million naira. So I am not saying that center you went to is fraudulent. The cost of care is so wide And in some situations, we are forced to use drugs. Thank God I thank God for the beautiful lecture we just heard from my former NAFDAC DG. There are so many times we just know our patients cannot afford these drugs. And we close our eyes and say, well, I know there is a better drug that you could use, but since this is what you can afford, let us go ahead. And then a woman is supposed to receive 5 or 6 cycles of chemotherapy. And you walk into the chemotherapy room, she has just completed her 4th cycle. And the disease that you expected to shrink is getting bigger. And you say, madam, what is happening? Okay, before I can conclude that this drug I am giving you is, the disease is resistant to this drug, let's just do one thing. The next time you come for your chemotherapy, it's still the same regimen, but please buy this exact brand. On 3 occasions, women have come into my office crying. Why were they crying? Because they just took 2 cycles of the same regimen that they have had 4 or 5 cycles before, and the impact was so drastic. And the reason they are crying right now is they are just imagining how they would have done much better if they had used the correct drugs. It's the same name, it's the same thing, but different companies. But of course, that was what they could afford. Like I said, it is no respecter of anything, not even a respecter of age. Just 3-4 weeks ago, the urologist in BSUTH can bear me witness. I saw a baby in BSU Teaching Hospital Oncology Clinic that was just 13-14 months old, diagnosed with cancer 10 months of age. As at when I was seeing that small girl, one of her kidneys was already gone. That is how bad the situation is. Babies are born with a malignancy. Thank God my teacher that I acknowledged earlier is a pediatrician. Babies are born with malignancies that before, the mother may say, oh, I noticed it when the child was 10 years old. It didn't, 10 months old. It didn't start when the baby was 10 months old. The baby was probably born with it, and it just took 10 months to grow gently before becoming what the mother will notice when bathing the baby and say, what is this? And then issues will start. That is the scenario we are facing. I just had to mention this so that we will see the significance of, oh, I didn't realize that it is already projected. I would have moved much faster. We will see the significance of what is going on. I think you can just move until you get to the place where there is one beautiful good. Well, it's difficult, come back. It's difficult for us to see, but what I try to do is to make us realize that cancer care, whatever it is never a one-man show. There is a combination of so many specialists in the management of cancer. As in, any one person who owns one small shop somewhere and tells you, bring all your cancers, I can manage it, I am Gbogbonishe, run away. That person is fake, even if he's carrying a medical certificate. Because the doctor, the oncologist, I usually run away when everybody says oncologist. I'm a radiation and clinical oncologist. I will need the surgical oncologist. I will need the pathologist to even tell me what kind of cancer I'm dealing with or not. You need the radiologist to help you make your diagnosis, to help you do your metastatic workup. You need literally everybody within the health sector. I have just called doctors. The pharmacists are there. These drugs must be well handled and processed by the right people. The nurses are there. Whatsoever you do as a doctor, if your nursing care is 0, your patient dies. I am talking of literally everybody within the health sector. The nutritionist is there, the physiotherapist is there. So when you talk about a cancer center, especially you are talking about an ultra-modern cancer center, a one-man show. So what is an ultra-modern cancer center? I will just summarize it by saying it is a very, very standard center that has the most advanced of techniques. And I think that definition will just suffice. Because you are saying in surgery, you want to be able to even do robotic surgery. You want to be able to do all your laparoscopic surgeries. You are saying in everything you have the most high-tech. In your diagnostic tools, you want to be able to do a PET scan. Unfortunately, there's only one PET scan station in the whole of Nigeria right now. Only one place does a PET scan. As important as a PET scan is, We have only one place in Nigeria to serve over 200 million people. I have worked temporarily in some countries where in one facility, the whole of the 7th floor has PET scan machines up to 5, 6. That is one facility, and so many other facilities have. And yet, for the whole 200 million Nigerians, there's only one, and it's private. That is where we are. When Dr. Adewale mentioned earlier, maybe it didn't sink in. When IAEA and WHO says you need 1 linear accelerator to a million population, and Nigeria has 200 million people in the list, and we know we expect to have the minimum of 200 linear accelerators in Nigeria, guess how many we have? Not more than 5 or 6 that are functional. In fact, up to just like 6, 7 years ago, there was only one, like he mentioned, that was epileptically functional. I don't want to mention the center, but it was our hope. That means invariably everybody from the whole country, whether from Meduguri, whether from Lagos, whether from Rivers, were all trooping to one center. Then you have a patient that needs urgent radiotherapy, and we are looking at our schedule and saying, my guy, you cannot get this treatment for the next 6 months. The patient is sitting and dying in front of you. It is that bad. I am mentioning some of these things for us to just get a better idea. I will not go through most of the technicals. I wish we will be able to get the slides. But having this thing as close to home is one of the best gifts we can ever have as a system, as a state. And you will not see, it was mentioned that I went to help set up the Asiupo Comprehensive Cancer Center. At the interview, something that has never happened to me happened. I was explaining how Benue patients suffer, and I was crying. It was that bad. If you have stood as a doctor and watched your patient bleed to death, when you can simply use hemostatic radiotherapy and that patient stops bleeding, you will know what it means as a doctor. It's one of the most painful things that can happen to you in your profession. So many times you pack up a woman with CA cervix that is bleeding. You've done everything. You can't do anything more. You have given blood. You can't keep giving blood. You carry a bleeding woman and put her in a vehicle and say, please go to Abuja, and you hear that she has died before she got to wherever. That is how bad the situation is. You have a patient that has a spinal metastasis that technically you can make that patient walk again. Then you package the patient and put in a taxi and say, please go to Abuja or go to Calabar. Before the patient even gets there, the potholes on the way have completely knocked off what you were trying to preserve. That patient never walks again. These are the things that are being saved for us if and when a situation like this comes to be established. So it bears everything for the patient. Saves a lot for the patient financially. In Calabar then, whenever anybody calls us and says, how much is radiotherapy? We'll say, yes, it's 1.5 million naira, but please hold like 2.5 to 3 million naira before you come. And they will say, what? Then we start telling them, you will have to be around for 5 to 6 weeks. You will have to stay in a hotel. You will have to feed. There are other ancillary investigations. Now, this is, imagine, like I said, about 3,000 plus people annually needing to take this much amount of money out of Benue State on an annual basis. Significant capital flight. So you are not just talking of saving money for the individuals. You are talking of significantly improving the IGR within your hospital. These patients are not just going to receive chemotherapy. They are not just going to receive radiotherapy. They are going to do series of investigations. So the lab that is currently being underutilized significantly gets a shoot up. Our radiology facilities that are currently getting underutilized, because these investigations are basically part of the system. So a lot of the ancillary sectors within the hospital just begin to significantly generate IGR. I know that when I was in Calabar, the hospital was being sourced. It was a hospital before they established the cancer facility. But the cancer facility was literally sustaining the hospital. It's that much. And that is what we are thinking about. So it affects not just the patient. It affects the health facility in all of these various sectors, in all of the ancillary sectors, and then it significantly affects the society. Somebody had mentioned, and that's why I do not need to keep reiterating it over and over again, how even the woman who sells food on the streets is likely to feel the impact that there is something in the town that is new. Because you will have a lot of people coming from Taraba, from Nasarawa, from surrounding states that need to stay in a hotel, that need food to eat, that use your transportation to commute left, right, and center. Eventually, you are talking of just one thing that impacts significantly on the whole healthcare system and on the whole livelihood system within a state. It's not a joking matter at all. I think I would not, you can just be running the slides as I speak because I am literally rounding up. I promised us I will try not to talk for more than 10-15 minutes, and I think I have to do that before I get the notice to sit down. So, a one-stop cancer center, just to emphasize, is that center that tries as much as possible to cater for all aspects of the cancer care continuum. And what does that mean? From prevention to detection to treatment to palliative care if necessary to survivorship care, all the aspects of cancer care. That means the society at large is even going to significantly benefit from the preventive aspect. You see, the bane of cancer management, why many people see cancer as a death sentence, is just the stage of diagnosis. If a cancer, most cancers, once they are caught in stage 1, stage 2, you expect the patient to get cured. Now, when you have a center situated, that is where all of those preventive measures can be very easily organized. So a lot of awareness talk, a lot of community engagement, a lot of screening, you get to begin to detect these cancers. If somebody, very early, if somebody as lofty as His Excellency, my former Senator Gabriel Suswam had mentioned it, I do not need to repeat it anymore. All of these things I'm saying have been said over and over on this very podium that I stand. So it's a very, very lofty program that involves every aspect: comprehensive diagnostic services, multidisciplinary treatment, integrated care teams, patient support services, advanced treatment techniques, everything, bringing them under one roof to ensure that the patient gets the benefit of being able to just say, I am not sure of what is wrong with me. Walk into the hospital, and the hospital, from that point, the patient does not necessarily need to go anywhere else for any of their major cares. They get everything done under one roof. It's a beautiful vision, and it's something that we really, really look forward to coming to stay. I am glossing fast through slides because I know that I might not have more than 2 minutes more. Now, maybe I should just also mention that the Federal Ministry of Health, the federal government actually has beautiful programs. There is the general belief that cancer care, cancer treatment is so expensive. But the federal government, the Federal Ministry of Health is doing a lot of things, coming up with so many beautiful programs to try to alleviate the suffering of the masses with regards to cancer treatment as much as possible. There are programs like the Chemotherapy Access Partnership Program, where a patient just gets to pay 50% of the cost of their chemotherapy drugs, and they get the best quality drugs. There are programs like the CHF, Cancer Health Fund, where patients actually get money directly from government because they have been diagnosed with certain cancers. But you see the issue. The Federal Ministry of Health will insist that they will not even recognize your institution at all to benefit from any of such programs. They will not even recognize your patients as can be beneficiaries of such a program, even when they are also Nigerians, because you do not have certain facilities, particularly a radiotherapy facility within your center. Because before you can fully be recognized as a center that offers good comprehensive cancer care, you must at least be able to do surgery, you must be able to give chemotherapy, you must be able to at least give radiotherapy. In which case, how many of such centers exist? So you have beautiful policies that are supposed to be low-hanging fruits for our population, but they never get to access it. So many times we look at a patient, because we see how much they cannot afford for their care, we tell them, please, we know you are living in Makurdi, but can you just go and be registered as a patient in National Hospital so that you can at least access something that makes your treatment cheaper to a large extent. These are some of the things that my chief medical director is thinking of taking away heavy burdens from patients. Let me just mention, maybe before I sit, just a minute and I'll sit. You see, radiotherapy treatment, we keep saying 5 weeks, 6 weeks. The actual treatment on a daily basis doesn't last more than 30 seconds. Let me explain. The patient just comes into the radiotherapy room, lies down on the couch, everybody sets the patient up and go out. Within the next 1 minute, they are coming to say, okay, madam, we are through for today, come back tomorrow. In essence, these are treatments that people who have the facilities within their proximity get up to prepare for work, leave their houses, go into the radiotherapy center, receive their radiotherapy, and go to work. I'm trying to make us see the implication, how these things affect not just the long travels, but days away from work. So if a civil servant in Benue State has a radiotherapy center in Makurdi, that civil servant can receive his full treatment of radiotherapy without even the need to apply for 1 day sick off from his or her boss. But unfortunately, that civil servant will have to apply for 7 weeks minimum sick off. Imagine what that does to the civil service, to productivity within the state. So the issues are many, and we cannot begin to get to the bottom of it with one short lecture. But let us just know that this is, when it comes to stand, is going to be the one thing that will significantly change the landscape of healthcare within Benue and its environments and its environs. And the truth about it is that not just Benue people will thank us for that, but so many other people from surrounding states will significantly thank us for that. I do not want to belabor the issue of collaboration, because just having my royal fathers sit here is significant gainful collaboration already. When you see what they are giving and it looks like it starts and stops there, what we hope and look forward to is for the TOTIF to be able to galvanize our TIF sons and daughters in diaspora to say, this is our project, what can you do? Is for my Ochi Idoma to galvanize our Idoma sons and daughters in the diaspora to say, what can you do? When a king is sitting, that king is, you cannot quantify how much impact that king can have on whatsoever you are doing, because he is the voice of so many people, and that is what we look forward to, and hopefully we will get there. It is something that needs significant goodwill from the government, and what better goodwill do we need to be demonstrated than what we have seen today? I think I can run straight to my conclusion and sit down with all due respect and craving our indulgence, because there are lots of things. Okay, maybe 30 seconds to talk about an implementation roadmap, sir, because I had sat down and designed how over a period with timelines we could do certain things with specific activities and specific objectives, and developed it into just a very short document that is just 4 or 5 pages. I will submit that to you, sir, so I will not read it through here. But those are the things that we can look at as checkpoints to see what we must do before we do the next thing, so that we will not get to point D before we begin to get called back to do point A or B properly. I will submit that to you, my CMD, sir, and I'm very hopeful that it will guide us. So, in conclusion, let me just say that an ultra-modern cancer care center utilizes, please just go to my last slide, because there's a picture there that I will still want us to see, but an ultra-modern cancer center utilizes the latest technologies and multidisciplinary approaches to provide comprehensive care. domesticating an ultramodern cancer center in Benue State will require adapting advanced treatments to local context and building local expertise. Collaborations are vital in our quest to bring this center into our state, and involvement of various stakeholders and strategic planning is key. Whatever you are, whoever you are, whether you are a healthcare professional, a government official, an NGO member, or private sector representative, your contribution is crucial in transforming cancer care in Benue State. There was a diagram that I was hoping we would see, but I think technique, as in Hitches, might still not get us to see. No, it's not my picture. The slide before this is what I wanted us to see, but it just shows us how everybody, immediately after this, well, it's not even very clear, where I was just drawing a diagram where we know everything sits under our state government, but we will need the academia, we will need sons and daughters of Benue, we will need external collaborators. And the truth about it is that it can so impact on research that a time will come when even for Benue State University as a university, we'll begin to think that this auditorium is too small for some of the papers that we'll need to sit down here and present as a result of a one-stop ultramodern cancer center in Benue State University Teaching Hospital. Thank you very much once again for the opportunity to share my views. And I apologize that I had to rush because I really have to make out time for others to speak and for the panel discussions. Thank you very, very much, sir.
Thank you very much, Professor Otene. That was very brilliant and very interesting. Please, another round of applause for the only consultant radiation and clinical oncologist, Dr. Samuel A. Otene. Don't worry, the professorship is on its way. Ladies and gentlemen, without wasting more time, our next presentation is on what you can just see over there, towards attaining a one-stop hospital, and may I add, for cancer treatment. And our next presentation is from a professor of chemical pathology, Benue State University Teaching Hospital, and the former provost, College of Health Sciences, Benue State University, Professor Simeon Adebisi. Professor Adebisi, you have the floor. Please allow a round of applause for Professor Adebisi. Let's encourage him. He once ruled over these premises. Professor Adebisi.
The Chief Medical Director, other members of the high table, kindly permit me to stand on the already well-established protocol. The LOC approached me that I should talk on the theme of our summit here today, and that is towards attaining a one-stop hospital for Benue State University Teaching Hospital. I would like to start by saying that I feel honored to be here today to discuss this exciting prospect of transforming BSUTH into a one-stop hospital. And I would like to say that this vision signifies a commitment to providing exceptional patient care, encompassing a comprehensive range of medical services, all together under just one roof. And maybe the question that may be crossing our mind is, what do we really mean when we talk about a one-stop hospital? What really is the goal? What do we want to achieve? A one-stop hospital is also known as a comprehensive care center, and it offers patients a seamless health care experience. It provides a vast array of medical specialties. It's a place you will go to. You will meet the internal physician. You will meet the cardiologist. You will meet the pediatric oncologist. You will meet all aspects of medical specialty, all of them under just one roof. In other words, the core concept in one-stop hospital is to eliminate the need for patients to seek care at multiple facilities. The person that just spoke here now told us you have a patient at BSUTH here, but you want him to benefit from certain federal government provisions. So he has to go and register again at the National Hospital. And at a stage, you transfer him. But if BSUH should come to be what we want it to be, a one-stop hospital, all health care needs will be met just under one roof. And by the grace of God, we will get there. What are the benefits of a one-stop hospital for Benue State University Teaching Hospital? Number one is improved patient care. A one-stop approach fosters better coordination between specialists. They are all there. And with information technologists, with information technology, you are there in the clinic. You have seen the patient. You want a biopsy. You want an histology report. You want the PSA from ChemPath. You want the histology from anatomy pathology. And you are expecting that the patient might likely see an oncologist. As you are entering your data right there in the clinic with the appropriate IT networking, all the people that needs to do one thing or the other for the patient, they are already receiving on the spot. So every aspect of the hospital is networked together. And as a result, the patient gets better care with regard to whatever their health challenge may be. So that's one of the very important benefits. Another one is enhanced patient experience. Patients benefit from convenience of having all their medical needs addressed in a single location. Like it was said, you don't need to travel again. You don't need to think about hospital bill, or hotel bill in Abuja because you need to travel. But all of that will be eliminated. So there's enhanced patient experience while still seeking and receiving adequate medical care. Another advantage is increased efficiency. A centralized system can optimize resource allocation. You don't need to duplicate power supply for the radiology unit here, another power supply for the histopathology, something in another location, another power supply for the surgery. A single power supply that minimizes, expenditure, and you get value for financial input into whatever you are doing. So there's increased efficiency. Number 4, we are able to attract and retain top talent. Why? Because your facility will be known as a place where the specialist can best utilize his skills. All that he needs to do the best is there. And as a result, a one-stop hospital attracts and retain top talents. They don't need to say, I want to go to elsewhere. Why? Because that place I'll be able to do this and do that. All of that will be possible where you have a one-stop hospital. And lastly, it will position Benue State University Teaching Hospital as a leader in healthcare. By pioneering a one-stop model, BSUTH will establish itself as a front runner in patient-centered care within the Benue State and, in fact, its immediate environment. These are some of the benefits we stand to gain if we should all remain committed and actualize the goal of this, our summit. However, nothing good comes easy. There will be some challenges. What are some of the challenges and considerations we must be conscious of as we are planning a one-stop Benue State University Teaching Hospital? Number 1 is infrastructure development. Transforming BSUTH into a one-stop hospital may necessitate expanding or renovating existing facilities to accommodate new departments and new equipment. If you look at the brochure for this program, you will see a drawing of a cancer facility. We already have an hospital, but there's already a thinking that if this will be done, we will need this. So if you are going to have a one-stop hospital, there will be need for you to do a retouching to your infrastructural facilities in the hospital. Number 2 is human resource development. There will be to ensure adequate staffing across the various specialties. This will require strategic recruitment and training initiatives. In other words, you do head hunting. You identify a need. Maybe you need a pediatric surgeon. So you head hunt for a pediatric surgeon. Maybe you need a neurosurgeon. You head hunt. So there will be human resource development for us to achieve that goal. Another thing is technological integration. A robust IT infrastructure is crucial for seamless information sharing and coordination between the various departments in a one-stop hospital. And lastly is financial planning. The transition will involve careful financial planning to secure funding for infrastructure, to secure funding for adequate staffing, and indeed to secure funding for technological advancements. So there will be need for us to sit down and do an adequate financial planning. So the last thing I will be talking, my talk will be brief, is on the road ahead. So how do we do it? The guest speaker that spoke here today gave us an example of how the cancer center in Lagos look like. And I'm very sure if you look at where you are working, you will discover that there is a gap between where you are and the place he's talking about. And now as we are talking about having a one-stop hospital, without any doubt, there is a gap between where we are today and where we are proposing to get to. So how do we move from where we are today and get to where we want to get to? Here are some initial steps to consider. The first thing is conducting a feasibility study. And here there will be a thorough assessment for us to identify the necessary resources, infrastructural upgrades, and financial requirements for us to get to where we want to go. You'll be able to define we should be able to define what are our needs that will take us to where we want to get to. That is the focus of the feasibility study. Assessing yourself, knowing what you have and what you don't have, then where you want to get to, what's the difference? And what do you need to do to cover the difference? Secondly, after the feasibility study, will be the need for us to develop a strategic plan. Here, this plan will outline the phased implementation process, as well as the timelines and budgetary allocations, so that whatever, as you are moving from where you are to where you want to get to, there will be synergy in what you are doing, and the financial allocation will be able to cope as you progress from one step to the other. So strategic plan is very, very cardinal to our achieving our goal. And the third thing here is building partnership. There will be need for us to have collaboration with relevant stakeholders. You see, we talk about equipment suppliers. Now in Nigeria, we are beginning to see these suppliers who are ready to do what is already happening in the Western world. That's what we call equipment placement. They come and assess your place. If they discover that you have the patient load and that they to better use, they come and place the equipment at your place. And there will be a sharing formula. They will be supplying the necessary consumables. And as the patients come, there's a certain percentage they will take. You will take a certain percentage. So this kind of thing can be exploited. Another one is if it is a very, very costly diagnostic something, you can actually partner with some other well-established private laboratory like the PathCare in Nigeria to take care of certain things that you can't do for that point in time. So we actually need collaboration with relevant stakeholders. And like we started today, the who is who in Benue State, you gather them together. Let everybody be willing to make a contribution, because the financial needs, those people will not give you money, but where they can help you with equipment, they will do that. But you will still need money. So we bring in the stakeholders within the system and establish a very robust collaboration with all the relevant stakeholders. And lastly, will be to prioritize patient engagement. Throughout the transformation, keeping patients informed and gathering their feedback is very, very paramount, very essential. Let me share this with us. The American auto industry is much, much older than the Japanese auto industry. But what happened? Along the line, the Japanese auto industry overtook the American auto industry. They became well known all over the world. What was the difference? By the time the Japanese auto industry started, they put into it what we call a feedback system. You come to buy a car from them, they remain in touch with you. What are the challenges you are having? How do you think we can do it better? So with that feedback, they kept on improving on what they are doing. And as we two are progressing from where we are, where we want to get to, the patients, the end users of our facilities and care, we need to be interacting with them. What are the challenges that they are having? What do they think we can do better? So with this, we'll be improving on what we are doing from time to time. In conclusion, Mr. CMD, transforming BSUTH into a one-stop hospital is an investment in the future of healthcare for Benue State and the surrounding region. And by prioritizing patient-centered care, efficiency, and innovation, BSUTH can solidify its position as a leading healthcare institution. Let us work together to turn this vision into a reality, ensuring exceptional medical care for generations to come. Thank you very much.
Thank you very much, Dr. Adebisi, for that wonderful presentation. Please, let's give him another round of applause. Well, the handshake, well deserved indeed. So, all said and done, what do we know about cancer? Well then, to answer that question is our next presenter for today. He is a neurotoxicologist and also the founder, CEO, In-Country Medicare Limited, Abuja. I'm talking about none other than the eminent doctor, Dr. John Toragbidie. Dr. Toragbidie, please let's put our hands together for the neurotoxicologist.
Thank you. Can I go ahead? Okay. MC, thank you very much for that kind introduction. Let me just quickly recognize, the presence of my elder brother and also mentor, Dr. Samuel Toragbidie. Also on that note, I would also like to recognize Paul Ohi. Paul and myself have gone a long track back in the U.S. He was just reminding somebody yesterday that I have lived in the U.S. for over 40 years, and that is true. But the good news is that I'm back doing what I like to do most. There is nothing more than your own home. Home is home. Dr. Otene, Sam, you did a good job. Let me tell you one secret. Sam introduced himself as a clinical oncologist, but I would like to add an adjective on that. He's an integrative clinical oncologist. Because typically, an oncologist wouldn't talk the way, he talked. And you will see that in the course of my discussion. So, go ahead. You want to blink? Okay. Let's see. Okay. Okay, as I was introducing earlier, I'm the founder and CEO of In-Country Medicare, which is an integrative medicine center in Abuja. And what do you mean by integrative medicine? Just before Dr. Adeoye left, I just rushed out to meet him and asked him that you guys talk so much of what can be done with cancer. Do you ever think about integrating, integrative aspect of the cancer management? This is really key because for quite a number of years, President Nixon, the former president of the United States, declared war on cancer in 1970. Today is over 50 years, precisely 54 years. How much have we really won this war? Have we won the war? No. Apart from the fact that trillions of dollars was spent, and this message goes to the CMD too. Let us start on a good footing. Because what we've been doing in the last 54 years, we've treated cancer as if it is an enemy outside that came into the body. We treated cancer as if it was, a bacterial infection where you can easily use, antibiotics and it will go. But no, cancer is the same cells in the body that became cancerous. Just like we're sitting in this room. I can just ask by show of hands, how many of you are have your caps on? Then you are all seated in this room, that is the body. Then you come inside and try to, throw in mustard gas that it should kill only the people with, caps on their head. Is that possible? No. The answer is a capital no. It will affect everybody. And that's the mistake we have made. We've treated cancer as we focus on the disease in the body, but not the person with the disease. That is very, very, critical for us to understand. So there should be a holistic or an integrative way of managing cancer. After all, in integrative medicine, we don't use the word, treatment. Because cancer is nebulous, multifactorial, multi-systemic failure of the body systems and then organs. Very, very complicated. It takes 10 years for that one cell that became notorious. It will last for about 9 months and then thereafter they become 2. Those 2 cells, it takes up to 2 years before they start multiplying rapidly. So we got to understand this, that we are dealing with a monster that has actually taken about precisely there are 10 biological events that goes on in the body once those cells establish independent. So we say cancer is an acidic disease. We say cancer is an inflammatory disease. Cancer is an immune compromised disease. Cancer is a hypoxic disease. What do I mean by hypoxic disease? Basically, cancer cells do a different metabolic pathway for production of energy, what you call ATP. Typically, in normal cells, we undergo what we call aerobic respiration. But cancer cells, once they become stubborn and pathways, they develop the system. They start producing energy by fermentation, which is a very primitive way of doing it, because typically when you take one glucose molecule, you produce 36 ATP with aerobic respiration. But in case of anaerobic respiration, you produce only 4 ATPs. Those of you who are biochemists can figure out. I'm sorry I may have to talk in this way, because you see, we really want to go to the problem, because a good general, before he goes to the war, he must understand the strength of his enemy. In those days, I don't know whether people have an answer now. Even oncologists, you ask them what causes cancer, they'll tell you nobody knows what causes cancer. But in the couple number of decades, we've come to know, and it's been published on the U.S. National Institute for Environmental Health Sciences web page, that 90 to 95% causes of cancer, they are actually due to environment, that is lifestyle. If you look at it, cancer has taken really much of our time. They looked at about what they call somatic mutation, theory, where they say that it is some kind of mutation that is going on in the body. Come on. We've come to know today that in a day, you and myself will produce over 10,000 mutations. If actually cancer was a mutation-derived disease, our body would have been filled with mutations all over. Then President Clinton in 1990 came up with what they call the genomic study, where the 25,000 genes of the human being were actually mapped out. That, cancer is actually inherited. No, only 5% of what causes cancer is due to genetic disposition. Even then, because we know 75% of the genes we inherit are actually dominant. The 25% that can be expressed, they have to be triggered. And that's why we say what? The genes load the gun, and it is the environment that pulls the trigger. So the idea of saying, that, by the way, Dr. Ohi, I was just going to make a remark that you will sleep very well tonight, and just like myself. For the past years, we've been looking for an opportunity like this where we can come in and make contributions. This is the first time we have identified some seriousness. So the CMD, I must congratulate you on the bold step that you've taken, and we're all behind you. We will support it. Come on, let's get back to cancer. So what I'm telling you is that if you look at it, Otto Warburg, who was a Nobel laureate in 1924, came up what they call the metabolic theory of theory. We have looked at what you call the somatic mutations. Otto Warburg came up and said, look, those cells became cancerous because as the body is overtaxed with acidity and the accumulation of toxins, they cannot undergo the normal respiration. So they parted. And once they part, they cannot use oxygen again. And that will now make sense. Why in integrative medicine we use ozone therapy to actually manage cancer patients. Because cancer patients do not thrive in oxygen-rich environment. Period. So, same thing when you talk about acidity of the body. If you're treating cancer patients and detoxifying and removing the acid in the body, you're adding additional chemicals into you will not achieve much. So in integrative medicine, we do emphasize what we call the fundamentals of disease management, which involves detoxification, involves what? Cell membrane optimization, and then intravenous nutritional therapy. Because we've said that cancer is an immune compromised disease. So if your immune system is low, that is where cancer would come in. If not, as the cells are becoming, those of you who are chemists or scientists, you know what we call DNA repair. Those mutations that happen to DNA, I mean, the immune system is trapping those wrong ones and even fixing them back. Please, let's move faster. What? Oh, okay, thank God. So I had just made an initial introduction of our services. We render immune support, wellness, disease management, and disease reversal. Some of you will be surprised to hear that hypertension and diabetes can be reversed. We do anti-aging medicine and then cancer medicine. Move. Then, well, it's a group of us who had lived in the United States for so many years. I'm talking about in-country Medicare. We came back to establish this, and we have our partners all over US, Germany, and then Dubai. So what is cancer? We've started that story. So see what is it. Let's see this summary. At the end of this presentation, I'm hoping that we will de-identify the key hallmarks and traits of cancer. We understand cancer's is a unique process of disease development. And we gain a working knowledge of cancer and know how best, we know that cancer cells actually invade and they also cannot be attacked by the immune cells. In fact, if you want to know, cancer cells, the most problematic posture of cancer is what we call circulating cancer cells. These are the ones that are able to move from the site of origin and then go. So if we say if you're just focusing on the breast because you've identified, made some histology there and seen that you have either a triple negative or whatever you call, the circulating stem cells have already moved and escaped round over the body. And that's why in management we talk about cancer-free and cancer-proof. You can do integrative, radiation, do all this at that spot. There's no doubt about that. You kill cancer cells, but those circulating cancer stem cells have moved away. So you must do something to address that, because that is what happens. After 2 years where somebody is declared cancer-free, and then he comes back. And when the remission comes back, it's even worse because his immune system has been compromised and they die. So we become sad after celebrating that he's cancer-free. Now the person gets back, worse. So a number of questions, but let's just go ahead. You can read it. Yeah, actually, MC, usually I don't do 5 minutes talk. In Abuja and other places, when they ask me, for 5 minutes, I say I won't take it. Even 15 minutes, because this is my passion, and a lot of us don't understand what is happening. Albert Einstein told us that if you continue to do the same thing over and over, that is definition of, and expect the same result, that is the definition of, insanity. what I'm saying here, even if I don't say anything now, my time is over, I'm going to sit down. We have to use an integrative approach in cancer management. And you see what we call the 7 key principles of, cancer management. I will just run over that and I can go. Go. Okay. This is cancer, is nebulous. I've already talked about that. Explain what is this. This year alone, you have over 2.5. We have not lost the war. Something has gone on wrongly. Since the war that, President Nixon, declared, and we've been doing all these things. For over 50 years, if you look at the statistics, the success, especially of stage 4 cancer, is just 2.5 million. 2.5%. Most cases, once, just like Dr. Sam said, when you go to stage 4, it's really very difficult to walk you back. But it can be done. Go. So questions, yeah, we have spent so much. I've said that. Let's move. And I've answered the question whether cancer is a genetic disease. I would also like to leave you with what we call the energy deficit theory of aging and degenerative diseases in general, and what we call oxygen utilization. There is that map. Let me show you. A schematic draw. You have certain number of factors that will decrease oxygen utilization in the body. Then you have decreased antioxidant, checking effect. Then you have ultimately the mitochondria dies. It is when the mitochondria dies that actually there is real death. There is mitochondrial decay. When you are at the level of mitochondrial decay, disease can be reversed. But when you go to mitochondrial cell death, bam, it has finished. Go. Well, typically, I just want to summarize this concept to you. There's what we call membrane optimization. When a toxin hits a cell, the cell has 3 options, which I said earlier. Either it will undergo DNA repair and fix itself and become a normal cell again, or it will commit suicide. That is what we call apoptosis. And if it cannot do any of those 2, that is when the cell undergoes abnormal changes. That is how a cell becomes, cancerous. I had said it. It is very important. Well, this is the partner we started. 3 milestones: somatic mutation theory, the cancer genome. I've talked about the metabolic theory of disease. We've talked. Then go ahead. You know what somatic mutation means. I have understand. Then the atlas. I've talked about it. Go on. Okay. So, let me just take you straight to what we call the 7 key principles for cancer management and cancer prevention. Go, run through them. Yeah, that's what we say. The genes load the gun, and my friend Paul was laughing, but that is it. Otto Warburg, I've talked about him. Go ahead. Go to the 7 key principles. I will just summarize that. 7 key principles basically just mean 7 things we can do to our body to prevent cancer or manage cancer. Today, there are several products that have come up. One amongst them is vitamin C. Although vitamin D is also important because it plays a key role in our immune system. But vitamin C selectively kills cancer cells just like what? Chemo. Without damaging, the normal cells. This is what we call non-toxic, therapy with vitamin C. So we manage cancer patients by giving them what we call Mayer's protocol, which is a high dose of, vitamin C. And why is that relevant? If you look at the structure of vitamin C and that of glucose, because cancer feed mainly on glucose. That's why we say that cancer cells are obligate metabolizers of, glucose. So if you are able to block the receptors for the glucose by giving high dose of, vitamin C, the cancer cells can no longer use, glucose. So by doing that, you selectively kill them. So go ahead. Those are other methods we use. Heat. You can use the temperature to manage and treat cancer patients, just like disease. Because there is one great guy that said, "Give me a fever and I will cure all disease." So when you are sick, there is fever. It's a way of managing. These are the 7 key principles that I was going to talk about. I talk about this in vitamin C, what is called the non-toxic therapy. Then you talk about microbiome optimization. If you look at it, what do you mean by microbiome? Today, we've come to know, gone are the days when we were told that, yes, our immunity comes from the spleen, comes from bone marrow, comes from this. Today, we've come to know that 80 to 90% of our immune system actually comes from the gut. So if you optimize your gut, and then your body is able to, protect you or against a lot of diseases. Then the gut, to work with the gut, you need what we call probiotics. So after you do that enema detoxification, then you use a probiotic to balance between the population of the good and bad bacteria. It's one of the key principles. Another of the key principles is to use oxygen. I've already told you how oxygen actually cancer cells cannot survive in an oxygen-rich environment. So people keep asking us that, why are you using ozone to do this? Yes, ozone is a potent source of, oxygen. It is a triatomic, molecule. So when you give it, then the cancer cells are able to die. Not only that, ozone stimulates the immune system, is anti-inflammatory, it's also an antioxidant. In these days, when you're talking disease and you don't mention inflammation, immunity, and detoxification, you've not started. That is what is going on. So those are the key principles. Then things like even spirituality. There's what we call toxic emotional toxins. People in bad, relationship, lack of forgiveness. One of the best integrative doctors, they call him Tony Jimenez. He's actually in Texas, but he is practicing outside in Mexico. He was treating this woman with all the functional modalities. He is an MD. He has combined all aspects of conventional and then non-conventional means, and he's doing great. He can take people out at even stage 4. He was treating this woman. The woman was not responding. So, and he also has churches where they do counseling. The woman confessed that when she was young, her father and uncle had abused her, and she decided never to forgive them. The moment she let go, she started responding, to treatment. So cancer patients should be counseled along spiritual lines too. So those are the 7 key principles. These days, as I'm talking, you can just Google any of these things and you see whether John is, talking truth or talking trash. But the 7 key principles are there. If you Google now, you'll see it. Let's go. So this is good for, then there is what we call health optimization. You all this work through a protective and enhanced immune system. You have to manage your stress very well, take right amount of water and then hygiene. Sleep 7 to 8 hours. When we talk about sleep, without good sleep, you are almost crashing your own self. Yourself. And then you talk about oxygen utilization benefit. Preventive care, dental care is really very important. Some of these diseases are associated with wrong dental care. And when you talk about oral and dental hygiene, it's very, very, very important. So most of you have have heard about what you call nitric oxide, which is a vasodilator that opens up your blood vessels. It starts, the production of that starts in the mouth. And that's why digestion should be very proper. And then then you practice fasting. I was going to take you through fasting, but just to cut it short, fasting is really, really very important. Each and every one of you should indulge in the habit of fasting. It has so many benefits. One of the greatest benefits of fasting is what is known as autophagy. Autophagy promotes the relightening or realigning of your skin with new collagen formation. It boosts the immune system. It's anti-inflammation. So emphasis on benefit of fasting, adequate nutrition, detoxification. I've talked about the microbiome. We talk about it, physical exercise and emotional spirituality. Yeah, go ahead. Autophagy, I've covered it. So go back to that slide. If I don't say anything, let me just conclude by that. That we should not focus on the cancer in the body, but we should focus on the entire terrain. And it is what I've tried to discuss. The different lifestyles that you've got to live, and then guide yourself against cancer. Go ahead, go ahead. So this is basically what we do in our center. We're an integrative center. We do things like OnDamed. OnDamed is a biofeedback, pulse electromagnetic, frequency detection. It's a German machine. You go on, it can really check. And talking about ways of detecting and managing cancer, you see, detection of cancer is really very, very important. Early detection. There are so many ways. It's not only through mammogram, maybe for women. In these days, we even use thermography. Thermography is a test of, physiology. And if you, as you said rightly, thermography can pick up cancer even 2 or so more years ahead before it sets in. So I'm just hoping that once we establish this center, we should also go to the use of, modern equipment. Mammography is what we call a test of anatomy, but well, we use it in this part of the world most. But elsewhere now, there is less emphasis on, mammography, because it puts a lot of pressure. And again, before mammography picks up a tumor, it has to be a size of 0.5, cubic, centimeter, and a 0.5 cubic centimeter tumor represent over 1 billion cancer cells already. So you want to use things like thermography. Thermography can just detect less than 400, cancer cells. It is better managed at 400 than you're talking a billion. There's so many of those ways. Then we have a product known as BSUTH, which is a biotherapeutic, benefit, which those of you who came to our stand yesterday, you see what BSUTH is. And here I must commend my brother. It was during his time that we were able to register BSUTH. Nigerians used to go to Cuba, to go and buy this, but we now have it now. BSUTH has so many benefits: anti-inflammation, immune system stimulation, and restoration of appetite. So we have that. Go ahead. So this is what people are just testifying about BSUTH. Then Professor Weselin has said this: I am under obligation to make known and to also demystify cancer. Many people feel it's a death sentence. By the way, cancer is not a sentence. Cancer is a word, but we say it's a death sentence. It can't be that is just a human. Okay, family fees and friend, colleagues, once they begin to look at you and feel you are hooked up, you are ghost once there, and there is no hope. But he has undergone treatment of cancer, and I'm able to tell you that I even have that certificate. Finally, I finished in that October as he specialized season. So, in conclusion, discovery consists of seeing what everyone has seen and thinking what no one has taught. So there are very many new ways, along with conventional modalities. Let me cite this example. In our center now, we're managing cancer patients along with ABU Teaching Hospital. And when you give them things like vitamin C to boost their immune system, you give them ozone to boost this. When they go there, Professor Olasinde would even use a lower dose of chemo on them. And we're getting, when we first started, our first patient, he had gone to, after we prepared him and she had gone for, chemo, she was very surprised. After 6 cycles, this woman was driving fine and good. And after they did all those biomarkers and now of cancer, they thought that many of them are gone. But in conclusion, let that not deceive you. You are cancer-free but not cancer-proof. To be cancer-proof, it takes actually 1.5 years of continuous treatment and then management. So I want to thank you for this opportunity. CMD, thank you. And everybody and my brother, I think we can sleep. we can sleep better today because we have actually achieved what we really want. Yes, we've been looking.
Please, more round of applause for him. Dr. John Taragbide. We appreciate you for that wonderful presentation.
Indeed. If you are old enough to be vulnerable to cancer, then Dr. Toragbide's presentation will make a lot of sense. I have, a bottle of vitamin C standing at the top of my refrigerator for ages now. So I guess when I go home, I'll start making very good use of it, since it is a catalyst in the prevention of cancer. At least that one is very accessible to me. Ladies and gentlemen, up next we have a more participatory session this time around, but I have the honor and privilege of inviting Professor Michael Agbi to handle the introductions.
Just before Professor does the needful, please, in case you are yet to make any donation as regards the fundraising, a room is yet be made open for you to be able to key in. Please, the account number was placed for you to copy. I have yet the account number with me in case you need it for transfer. Beckon me, I will be at your beck and call. I have just been hinted in a tete-a-tete that the Catholic Bishop of Katsanala Diocese has given his huge donation of 200,000 naira. Please, a round of applause for him. Even after the event must have been over, please, the room is yet there for you to be able to make your contributions. Easily call on the CMD or any of the management staff, and of course, the account numbers will be available to you for you to be able to make good use of it. Thank you.
Well, before Professor Agbi continues, I just quickly was able to get the account number. We may not be able to display it over there, but please, let's just pay attention. It's a First Bank account number 2044 104180. First Bank 2044 104180. First Bank, and the account name is BSU Teaching Hospital Project. So you have the account number now. The donations and contributions continue. Professor Agbi.
Thank you, sir. Before I move on, can we just rise and give a standing ovation for all the presenters? Dr. Pohi, Dr. Otene, Dr. Toagbide, Professor Adebisi. Sir, I thank you all. Please, can we wave at them like this? Can you carry your hand like this? Can you take the other hand like this? Okay, can you bend backward? Bend forward? Okay, we can now sit down. Okay. So the next and the last, almost the last round of this summit is on a panel of discussants. We are going to make a minor discussion on this so that we fast track the presentation. First, let me call on Dr. Paul Botwe Ohi to step up and sit at the center seat there, sir. Can we clap our hand for him? He's going to take all the comments on counterfeiting or medication. Next, I call on Professor Edwin Esegbe, a former Chief Medical Director of Benue University Teaching Hospital, a consultant pediatrician, and currently the HOD Pediatrics at Benue State University Teaching Hospital. Sir, you are welcome. Next, I call on Professor Andrea Onguze, a consultant obstetric and gynecologist at Benue State University Teaching Hospital. She is currently the HOD Obst and Gyne. And because we all know that cancer, particularly the cancer of the cervix, is also a common prevalent in our environment. So it is good for gynecologists to throw some light on that. Professor Esegbe, being a former Chief Medical Director, may also tell us a little more about achieving or how to attain a one-stop hospital. Sir, you did it before. and I think you will share your experience with us. Next, I'm calling on Professor Joseph Ngbea. He was here. Professor Joseph Ngbea. Okay. It's like he has stepped out. So we also call on Professor Barnabas Eke. Professor Barnabas Eke is a consultant general surgeon. You know, surgeons are the ones that remove all the cancers. Remove your breast if they suspect that you have breast cancer. They remove lot of those viscera, intestinal viscera. They suspect that you have a cancer growth in that area. So Professor Eke has done a lot of that. He's here to share this experience with us. Professor Joseph Ngbea has just stepped in. Prof, can take your seat. Professor Joseph Ngbea is a former commissioner for health. He's a consultant anatomical pathology, a professor of anatomical pathologist. When you take biopsy to look at the cancer cells, the pathologists are the ones that would look at it and tell you the report, whether the biopsy is really actually a cancerous sample or not. These 5 important persons are going to anchor this discussion, and then we will receive comments from the background. We know that we have a professor of pulmonology also in our midst. We're talking to Associate Professor Bave. You know, cancers, there are a lot of lung cancer these days, sir. We want you to also make your comments on this. We have Professor of Hematologist in our midst, Professor Joseph Okuma. He's a professor of hematology. You know a lot of hematological cancers. We talk of leukemias, we talk of lymphomas. He's going to, if you have questions, he may take comment from there. So now we are all involved in this discussion. It's going to be a general discussion. They are going to anchor, and then we can also take comment from other members of this summit. I remain Professor Agbite Kuramaike, the acting chairman, Medical Advisory Committee of Benue State University Teaching Hospital. I'm going to moderate this session. So first, let me ask Dr. BSUTH Ohi to tell us a little about the effect of counterfeit medicine in medical practice.
Hello? Can you hear me? Hello? Oh, okay. Yes, I think I spoke about this this afternoon. The impact of counterfeit medicines in medical practice can be very huge. First and foremost, it increases the cost of care for patients because, like Dr. Sam said this afternoon, the patient, for example, took medicines, some courses of chemotherapy. After taking about 4 courses, they realized that the medicine was not working, so they had to just take the same medicine but from another source. And only 2 courses did the job. It tells you how expensive, chemotherapy can be, and somebody taking 4 courses, wasting money that they did not have. These are some of the effects. Counterfeit antibiotics and anti-malaria drugs are not only ineffective in treating the condition, but may even cause resistant strains of the microorganisms that are not even treatable by even the most potent medicines after that. Of course, some contaminants in counterfeit medicines, because of the nature of the places they manufacture them, can cause even long-term health issues, kidney failures, liver problems, and other issues. So, the effect of counterfeit medicine, even on the impact on the state budget for healthcare. The state is budgeting scarce resources to procure medicines that are not useful to the patients. And this is a waste of resources for the state. So there are many more effects of counterfeit medicines, but I will just stop from there at this point. If somebody has any more questions about that, I can expand. Thank you.
Thank you very much. Very distinguished Dr. Paul Botwevohi, former NAFDAC boss. Thank you so much for sharing your thoughts about the issue on discussion. We would now want to ask Professor Esegwe Edwin, the consultant pediatrician, who has experience with also the teaching hospital at Bingham. So would you like to share thoughts about attaining a one-stop hospital based on your own experience and prospects for the BSU teaching hospital, sir?
Thank you very much. The CMD, our highly esteemed guest lecturers, and my dear participants at this summit. Let me congratulate all the speakers on their well-delivered presentations. You could see they're all laced with experience, they shared personal opinions, and then the conviction in their presentation. I mean, it's quite convincing. I want to thank Professor Adebisi for his discourse on the one-stop hospital, but I would like to add a thing or two concerning the one-stop hospital. First, let me start by saying that the concept of the hospital is not a place, but an institution. So we shouldn't be thinking one-stop hospital is the hospital on Boko Road that you all have to come down there. No, it's the institution called Benue State University Teaching Hospital. That institution can be in any local government, can provide secondary, tertiary health care services, secondary health care services, primary health care services. In its ability to be a one-stop hospital, it's able to provide these services wherever you are in Benue State. So I just thought I should mention that, and over the country, and all over the country. One of the key ingredients that we must not shy away from, in addition to what Professor Adebisi talked about, is the issue of leadership and vision. Leadership and vision. Let me explain. We are having this summit here today, and I think if you look at the construct of Benue State University Teaching Hospital, there are only two persons that we regard as new. One, the executive governor. Two, the new CMD. Now, what that simply means is that this vision is a vision that is brought about by the inspirational leadership of those who are at the helm of affairs. And what that also means is that if those of us within the system, if we do not share in this vision, if these two persons leave, then we'll be back to square one. So the first thing we need to do is to make sure that we carry everybody along in sharing this vision. It's very, very important. And I'm happy that since he came on board, the CMD has been having several radio programs, reaching out to politicians, reaching out to doctors. I've never met Dr. Paul or he before. See, because of this program, I'm meeting him for the first time. So I think stakeholders are being sensitized enough to be part of this. So I want to implore on everyone, look at it as an activity for the greater good of Benue. Even when you are not invited, but if you know you have a role to play, please be part of this vision. So that's the first thing we need to do. We need to identify with this fantastic vision that is beneficial to everyone. Then I'll just expatiate a bit on what Professor Adebisi talked about, and that's the need for us to carry out an assessment. We need to do a needs assessment. Where we are coming from, what are the things that we need. That is very, very important. And I think we have all the facilities to be able to do that. We've talked about funding. Dr. Tene, thank you for being such a shining example of who, a wonderful student should be. Thank you for flying our flag. We are happy that the future is bright because people like you and the CMD are there. Thank you very much. It's very important that we take advantage of scenarios that we saw here today, the Royal Fathers being here, because it will require funding. It will require funding. Whatever we are doing will require funding. But I can tell you, when people key into things, you know, they will fund it. Once they believe in it, we've heard about donations, 500 naira, 1,000 naira, 3,000 naira. People, because they believe in this, but we should also reach out to them. There is need to develop the system. So while the governor has given us 2 billion naira, but he also has to help us with a lot of things. We can't have a one-stop hospital if communication is poor. We don't have good means of communication. If facilities, institutional facilities like where to manufacture the drugs, institutional facilities like having the right human resource, if they are not available, I'm happy we've had what's the name, employment of recent. So there is a need to also get to strengthen the health system, because in strengthening the health system, you are also helping the one-stop hospital, you know, to be a reality. It's very extremely important that in trying to be a one-stop hospital, we should not just be a one-stop hospital for tertiary health services. We must think about primary health care. We recorded fantastic success in our healthcare indices because we were able to deliver at the primary healthcare level. So we must incorporate the primary healthcare in whatever institution we want to build. But like has been said, we need to get this vision to be shared by people. We need to do a needs assessment. We need to come up with a strategic plan. We need to build or cost our strategic plan. We need to find a way of periodically reviewing our strategic plan such that we identify gaps and we move on. I think with that, and with everybody's commitment here to ensuring that we enjoy this benefit, I think with sky is the limit. Kudos to the CMD and a shout out to our governor. They've all done well. Thank you very much.
Thank you very much, the very distinguished Professor Segbe Edwin. Please, we can give him a round of applause. And we heard you clearly. The needs assessment is critical. Everyone needs to be carried along. You appreciated the shining light of our capacity governor, His Excellency, and our Chief Medical Director, Dr. Stephen Wande, as well as specialists, including our very own Dr. Samuel Otene. And you also suggest that we reach out to more people for their buy-in, and then all facilities required to strengthen the health system need to be optimized. And the strategic plan is critical, and regular review to know what is left and what needs to be added on. And you also recommend that all stakeholders need to make their commitments and stick by that. Thank you so much, very distinguished professor. So we would now like to hear from the Amazon on the panelists, Professor Jose Andrea. When I went for house job, she was the one that signed me in. Federal Medical Center Makurdi, and coincidentally I started house job in her department. So Ma, would you be kind to share what the situation is, as you've seen through practice, with cervical cancer, breast cancer, and other cancers affecting females especially, and then what prospects exist for this when our cancer center, which is already in the process of being established, what do you see? Thank you.
The Chief Medical Director, or other stand on all other existing protocol. I'm very happy to be here to share my thoughts with you. Growing up, my father was a retired headmaster who thought teaching was the best profession in the world, and I hated teaching. But today, I'm very proud to be here to witness two of my past students in the person of His Excellency, Dr. Senator Gabriel Suswam, whom I taught in secondary school in 1980, after I graduated as a grammar student and worked as a classroom teacher, teaching English language and literature. And also, more recently, my star student in the person of Dr. Stephen Teungwa Wande. Both of them have done me really, really proud. So my father was right to say that teaching is indeed a good profession, and you get your rewards right here on earth, witness your products being such shining examples in the society. Be that as it may, I will just briefly run through common cancers that I've come across in practice. I trained in the University College Hospital, Baden, came back and worked at the Federal Medical Center, Makurdi, and then moved over to Benue State University and the Benue State University Teaching Hospital. And the cancers that we come across mostly in this environment are cervical cancer, cancer of the ovary, cancer of the endometrium, and gestational trophoblastic disease, which we brag that is one cancer that God created and man has been able to cure. And then breast cancer, which we fight over and share with the general surgeons. And in all these cancers, all we can do in Makurdi here is to make a diagnosis, take biopsies, send to the pathologist and confirm, and then we start looking for treatment centers. Most times we send our patients to National Hospital, and we find that one machine is working and another one is not working. So we send them up to Ahmadu Bello University in Zaria, teaching hospital in Zaria. They don't have relatives there. And then sometimes if they have relations at the University College Hospital, Ibadan, we then send them there, or Lagos. So our patients from Makurdi are being transported all over the country, sometimes without a good result. Sometimes they come back and say it's God's will, and they just die off. My last breast cancer patient that I saw was 2 weeks ago, who at the primary health center, somebody told her it was a boy and took the mass out and threw it away. And then she went into prayer until the breast cancer started metastasizing. And unfortunately, when she came in, she didn't even have a diagnosis. It was our pathologist, Professor Ojo, that had a look at the sample that was taken and wrote a referral to the general surgeon for the process to start. So our systems is in dislocation. We're doing screening, which is not organized. So I'm very happy that this one-stop center, Modern Cancer Center, is coming on board, where we'll be able to screen and we'll be able to treat in one sitting, using a multidisciplinary team approach. So I'm very excited to be here and to witness this historic event. Thank you.
Thank you very much, ma'am. Distinguished Professor Andrea Onguze. And you actually clearly said CA cervix, ovarian cancer are still most of the common ones, cancers that we have here among females. And basically what we've been doing are just doing biopsies, making diagnosis, and sending out for treatment. And then sometimes the machines have downtimes, and other places like Lagos, Ibadan, and Zaria have actually had most of our patients going there. But thankfully now, with the one-stop hospital, we're excited, and we trust that our clients will get far better care and spend far less to get the optimal care that is deserved. We would now like to take feedback from Professor Barnabas Eke, a general surgeon. And sir, I'm sure that you've seen, surgeons, use the scalpel very well. My dad is a surgeon too, so I know that surgeons don't joke with the scalpel. So sir, from your experience with the scalpel, how has it been with cancers? How has your care been for your clients? And what do you think would be better or what would change with this one-stop hospital with an ultra-modern cancer center, sir?
Thank you very much. All protocols observed. I have been debating for cancer management for the past 40 years. When I did my health job in 1981 in Federal Medical Center, then General Hospital Makurdi, I saw only one cancer of the breast at that time, throughout my 1 year health job. But now I'm seeing up to about 50 new cases of cancer of the breast in a year at BSUTH. Other cancers that we see in general surgery, cancer of the colon, and surprisingly, cancer of the stomach is becoming common, together with the cancer of the pancreas and the esophagus. It was said that those cancers were common in adult age group in developed countries, 70 and above. But now we are seeing 40-year-old with all these so-called rare cancers, esophagus, pancreas. But the commonest cancer we deal with here is cancer of the breast, which is overwhelmingly on the female side. And as I said, we see about 40 cases, new cases in a year. And we have been trying our best. In this center, we offer diagnosis after taking biopsies. We send to the pathologist who help us to make a diagnosis. The problem we have diagnosis is immunohistochemistry. Because now, if you make a diagnosis of cancer of the breast, it is useful to confirm by sending for immunohistochemistry. Secondly, immunohistochemistry is important for hormonal status of the woman. Because we know that cancer of the breast depends heavily on estrogens and progesterone by women for their initiation and growth. Unfortunately, we cannot do immunohistochemistry. So we have to send patients to Abuja to go and do immunohistochemistry. Then the other rare cancers, they don't need so much immunohistochemistry, but the cancer of the breast can present. So one of my excitement about this one-stop hospital is that we can now do immunohistochemistry in our center. And the worst thing also is that after using my scalpel and removing the breast for cancer of the breast, particularly early cancer of the breast, because we do mastectomy for early cancers, with a view to cure. After the wound has healed, the will now come in for chemotherapy and then hormonal therapy. Then we have to send them for radiotherapy, which we don't have here. So they have to go to Abuja again. Or in the last few years, a center has been established in Enugu where our people go for radiotherapy. So I'm very, very happy. I'm very, very excited. Because if all these modalities for me to treat my cancer cases are here, I'll be very happy and our patient do not go far again. I was very sad when a woman told me that she went for radiotherapy in Abuja and their machine broke down, as they normally do very frequently because they are overwhelmed. So the woman had to travel to Sokoto from Benue State to do her radiotherapy before coming back. For other cancers that we encounter commonly, colon, of course, mostly surgery and chemotherapy, and they are okay. Esophagus and the other ones, they don't respond so well to chemotherapy, but good surgery and some of them need radiotherapy, they are treated. So I'm very, very happy about these cases that are coming up. And this has been one of our drawbacks in our cancer management. But this one stage or 1 point cancer, I think everything is available and our cancer cases are easily available. So this is a very good thing, and I think that this is one of the major breakthroughs in Benue State in this century, because it will benefit not only people of Benue State, but the whole country and all over the world. So thank you very much.
Thank you, Professor Barnabas, A.K., a renowned general consultant general surgeon, Benue State University Teaching Hospital. In our midst, we have Professor Joseph Bea, former commissioner of health, a consultant anatomical pathologist. When I say I'm an anatomical pathologist, what I mean, they remove tissue and make diagnosis. I don't want to say that the ones that also conduct autopsies, but that is part of their jobs. In our midst, we also have another professor of anatomical pathologist. That is Professor Ojo. He's also in our midst. Sir, I recognize your presence. Professor Joseph Nguea, can you quickly tell us about the pattern or distribution of cancers in Middle Belt and in Benue State in particular, based on your experience so far?
Thank you very much. I sincerely want to thank the organizers of this forum, the CMD, extending to His Excellency, the Governor of Benue State. I want to thank the presenters, Dr. Attaining, our former provost, who did a wonderful job too. I thank all the participants. I also thank my senior brother in the profession, Professor Babarinde Ojo. I want to say that cancers management is a big challenge, and cancer is a big public problem in our society. We have seen that to the latest man knowledge, any growth that is abnormal, distorting the normal anatomy of the body, will be questionable. We could have those cancers that have no problem, they call it benign. Then we have cancers that are malignant. We are more concerned about malignant cancers because they are the ones that has high morbidity and mortality in our world. So technically speaking, if you have students here, they will be telling you that abnormal growth of tissue, even when you remove the initiating stimulus, it will continue to grow purposeless, uncoordinated. That is how cancer is defined. Looking at the statistics of cancer across North Central, across the world, across Nigeria, you could discover that there are no palpable statistics of cancer that are very known to be exact, even most especially in the developing countries like Nigeria, because people that have, just like we've heard, people that have cancers, some of them doesn't seek orthodox care. Some of them believe that they are spirit from their great-great-fathers from above. And so some of them tends to go to traditional healers or prayer houses. And for example, in Africa, 1% of the registry unit of the cancer appears in Africa. But in the world, we have 64% in Europe that cancers are registered. That means that in our country, the problems are that we don't have registry unit of cancers department, cancer registry department. The reason is that larger population do not attend the hospital. We have inadequate diagnostic facilities. We have limited access to care. We have non-functional cancer registry. For example, in the whole of Nigeria, we have 11 cancer registry. The first cancer registry was in the University of Ibadan, UCH, in 1960. The second was at Ahmadu Bello University in 1976. At BSUTH, we have a rudimentary cancer registry unit that we are yet to equip, we are yet to train manpower. And so what I'm saying is that many cases of cancer does not appear in the hospital. Let's take for the common cancers in female. We have the breast cancers, we have the cervical cancer. The breast cancers, like my colleague here, Professor Eke, rightly mentions, they are very common. The commonness of all of them. In fact, there is no time. Just yesterday, I looked at close to 15 slides. We diagnosed many of them. And as he rightly mentioned, the breast cancers, we are making use of, they have receptors. Each cancer has a receptor in which it replicates, it propagates. And for example, the breast cancer have estrogen receptors, what I call the progesterone receptors and the HER2 new. And it means that if you target your therapy on these receptors, you will try to reduce the mortality and morbidity of the progression of this cancer. But we don't have the services here. Like you said, we send those patients in Abuja for immunohistochemistry. And it has been known that 66% of breast cancer patients are receptor negative. They are triple negative receptors. It means that you have to resort to other modalities of management for such patients. And so that is why they give estrogen receptors, progesterone receptors to many breast diseases without even knowing the type of breast cancer you are managing. And many of them, like in the world, they have been reduced. In the developed world, they have been reduced because of mammography. But here, if you look at women that are even this tall, you ask them reproductive age, you ask them, when last did you do your mammography? Very few of them will attest to us that they've done that. Because it's not routinely done until when you feel a lump in your breast. You go and see a doctor, and then the doctor will ask you to start this ancillary treatment. And so in our developing country, breast cancer and the histological subtype is what is called invasive ductal carcinoma. That is the most common in our environment. And even in BSUTH, there's a study that was done by Eke and co. I was also a co-author. That have been discovered that breast cancers, the invasive ductal carcinoma, is common in our environment, just like other parts of the world. People have done these studies in Jos, in Lagos, in Ibadan, and they have discovered that invasive ductal carcinoma is also common, the commonest breast malignancy in our situation.
Thank you, sir.
And then I've not talked about. I've not talked about. Okay, thank you. But I need to mention that.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir. Let's clap for him. Let's clap for him. You know, time is not our friend now. Okay. And so most of us have school runs and all of that. So let us try and fast track this process. Comments. Let's take few comment, clarification, and all of that. Maybe we count the number or highest 5 hands, and then we move. Overseeing Dr. To Agbide. 1.
Professor David Ondaka-Otumen is there, raising up his hand for a comment.
Okay.
From this end.
2. Professor Okuma. 3. Professor Himba. Okay, Professor Himba Hirekan. 4. Pharmacist Maria. 5. Pharmacist Maria HOD and Pharmacy. 5. Professor Priscilla Oto Dean. 6.
I think that's all. Because of want of time and for lack of it, a question and answer session we will entertain at this point in time. Professor is now
thank you very
expected
much.
to react.
Congratulate the panelists. We in family medicine, we strongly believe in the concept of bio, psychosocial, and spiritual aspects of disease, including cancer. So I strongly feel that 2 panelists are missing here, the psychosocial and the spiritual, because these 4 are the bio aspect of cancer. We are very serious about this. Over thousands of years ago, the wisest king on earth, King Solomon, wrote this: a cheerful heart is good medicine, but a crushed spirit dries up the bones. A cheerful heart is good medicine, but a dry or hot spirit dries up the bones. So if this is what has been on, and we forget about the psychosocial and the spiritual aspects, I think we are missing the road. So CMD, please, when you get those funds, make sure you divide them according to these principles. I'm happy that our governor is a spiritual healer, and he is the greatest contributor to this program. I'm sure you will take his advice on this. Thank you very much.
Thank you very much, sir. Number 2, please. Yes, sir.
My name is Dr. Tiotom Keku, Head of Department, Public Relations, Benue State University. I'm not speaking from the medical angle. I have 2 concerns. The first one goes to Dr. Paul Ohi on the issue of fake or counterfeit drugs. You know, anything fake is not good. Just like in communication, when we talk about fake news or hate speech, that's not good. But I think 2 ways to look at it is about self-regulation and also proper regulation. That will just take care of that. As all what we'll be saying may be elitist, because how many of us are educated to differentiate a fake drug from a genuine drug? So we need to get the players in the pharmaceutical industry to do their job thoroughly, not just wishful thinking, but they should go out and ensure that the fake drugs are completely eradicated in our drugstores. Then on the issue of Medicare, it's becoming so astronomical. We can't afford it. Feeding is expensive, education is expensive, transportation is expensive. So as we plan this one-stop hospital, we should be looking forward towards heavy subsidy so that the poor can also afford medical care. Thank you very much.
Thank you very much, sir. Catastrophic out-of-pocket expenditure is a big challenge with cancer care. Number 3, please. Yes, sir.
The CMD and the presenters and panelists, I stand on existing protocols. I feel, my name is Professor Joseph Aonduwasu. I'm a consultant hematologist. I'm professor of hematology. I'm head of department of hematology, to be precise. For the past 23 years, not as many years as Professor Ike, I've dwelled in the field of hematology, and for the past 18 years in Benue. I want to report that we have seen a lot of acute leukemias and chronic leukemias and lymphomas and many other disorders, malignancies related to hematological cells. And when the CMD came on seat, I ran to him. I was almost frustrated. And my frustration was, I've been here for so many years, and I cannot be sure that I've successfully managed some forms of leukemias, especially the acute leukemias. And what's the problem? The problems span from substandard drugs or counterfeit drugs to absence of the desired components and supportive therapies that are needed to build these cancer patients. And so I cried to the chief medical director. I was crying for just component therapy, which he assured me. But I'm very excited that the concept of attaining a one-stop hospital
And a cancer center takes care of a wide range of things. As you can see, a lot of conscious, even as amongst clinicians, because we're not integrated, a lot of us did not have the true consciousness to aggressively follow up and manage patients with cancers. Today, it is possible. We didn't have platforms to advocate for preventive interventions or for psychological support or for spiritual support as being propagated by some people. Today, with a cancer therapy, it is possible. I want to use this opportunity to appreciate the management of Benue State University, ably headed by our Chief Medical Director, for all that we have done in collaboration with your management team. But more importantly is to appreciate the consciousness that these presenters that they have brought for the main theme and the sub-themes to add to this discourse and to bring out the issues more clearly to us so that we appreciate more. We appreciate you all. Now, there's something that I want to ask my elder brother and my uncle, Dr. Ohi. Dr. Ohi is my elder brother, for those of you who know. When he came for youth service, I was a student in Jos then. He served, and then I used to see him. But after that, I didn't see him for a very long time. But that's for another day. Thank you very much, sir, for coming. Sir, this issue of, as a lot of clinicians have alluded to, on the issues of counterfeit drugs. For us in cancer therapy, it's terrible. The outcomes are not always good, and you're not happy. Sometimes you are even doubting your diagnosis. Sometimes you get back to fight with Ngea and Professor Odu and all that. They will go back and revisit the blocks and say, look, this is the truth. And then, once you change, you get a better result, as somebody also confessed. But, sir, the National Health Insurance Scheme, somebody also said here, there's a lot of research, grants for research and grants for support for cancer. What I'm not hearing, or what will you want to talk to us about, integrating cancer therapies in our health insurance scheme? Why is it part of our health insurance now? Or if not, what is the problem? Number two, can we advocate for genuine drugs from genuine sources to be given to us at the cancer center so that we can deploy it for our patients? In that way, we'll be able to circumvent the challenges of counterfeit drugs. But sir, another way to it is, even before the cancer center takes off, can we also have a support of cancer drugs specifically given to us through your many interventions to the hospital so that our patients can access them for free? Because the cost of care, just like my colleague has said, is very huge, especially when you put the cost of chemotherapies or drugs that are used in therapy. Is it possible that it can be made available free for our patients in our hospitals? Or are there NGOs? Are there any areas so that we can alleviate the suffering of our patients now, even before we start the one-stop hospital and then the cancer center? These are my concerns. Thank you very much, sir.
Thank you very much. I think they will have to respond at this point in time. Or do we have any?
Number 4.
Okay, number 4.
Number 4.
Please, let's be very snappy as regards our comments.
Good evening, everyone. I just want to commend the efforts of the deliberate effort of the CMD for bringing this platform for us for this discourse. One of the presenters was talking about the rise in incidence about some of these cancers, esophagus, colon, and the rest of them. I wanted to find out, is there anything to do with what we consume? Do you think what we consume currently could be responsible for the rise in incidence? And coming about the attending the one-stop hospital, because we have seen the need or the reason why many of the people in the community are resistant in screening, because when you screen and the diagnosis is made, you are wondering, so what next? This is just being told that I should put my house in order, you know, and we all know that when the patients present late, the prognosis is actually very bad. But the coming on board of the one-stop hospital is just giving us more work to do in the community to create awareness, and then the people coming to be screened, they also have the hope that there is going to be access for facility for care. So it is commendable. Lastly is the issue of data, because one of the presenter was also talking about you know, inaccurate statistics or not even being available. So just to highlight the need for data from day one, you know, data day one, day two data, day three data, so that when we are talking about our success story, it is evidence-based. Thank you.
Thank you very much, Professor Priscilla Amwesioto. I'll go to Professor Hemba Hileka.
I think that is the fifth to make a comment, or the sixth.
Are you five?
This is the sixth.
Sorry, I skipped number 4. It's my fault. Thank you, ma.
Thank you very much. CMD, high table, panelists, and members. Mine is just a comment. The issue of cancer management is very frustrating for both the doctor and the patient. We all know that it is a multidisciplinary area where you need a surgeon, you need a gynecologic surgeon, you need a pathologist, you need the pharmacist, and all these are specialists, including the physician. I think our CMD has a very tall dream. It's tall because it is what has never been done, let me say, in this country. No hospital is one stop. But if we all encourage him in this vision, I think he will make a success of it. He has two visions. One is to have a cancer center. Another is to have a one-stop. The cancer center is embedded in the one-stop hospital. Cancer center is very expensive. I remember many years ago, we attempted to establish a cancer center in this state. It was not possible. Even the funds could not be mobilized, not to talk of, you know, attempting to procure or even build the structures. There were so many booby traps along the line. The CMD, you are going to face the same challenges. I was the leader of that team. We went to many places. We went to South Africa. We went to many places where they were building cancer centers. We know that cancer centers have never worked in this country. But I know with your determination and direction, it will work. Build a team. That would be my advice. Build a team. And once you build a team with motivation and the charisma you have built, the sky will even not be the limit. Because this, I see this as the beginning of medical tourism. If you have medical tourism in this state, everything will be for the benefit of even the common man we're advocating. Drugs for cancer have never been cheap. It is a worldwide thing. they will never be cheap. But we know there are some groups that mobilize funds for treatment of cancers. We can approach them, and this will be part of the one-stop shop that we are talking about. So that for those who cannot afford, they can have assistance from NGOs and other groups of people. So I advocate that if you build this team, everything will be carried along. And at the end of the day, it is not just you, it is all of us will carry the glory for Benue State University Teaching Hospital. Nothing like this has been attempted before. I think that we should be grateful that we have someone now who is the leading light and who is carrying this flag along. We should follow him. Thank you very much.
Thank you very much, Professor Hemba Hileka. And we go finally to pharmacist Maria, the HOD pharmacist.
Good evening, all. My special appreciation to the CMD for this epoch-making event, bringing so many, both international, to converge here. I'm going to make comments on Professor Dr. His presentation on masking benefits of substandard and counterfeit drugs, or fake, what is called fake drugs. It's not one-man show. It required the collective effort of all of us, right from the regulators. First of all, the government support. If government will finance the regulatory agency in Nigeria, here we have NAFDAC, to do the necessary supervision, all the controls, and then regulate manufacturers, you will see that it will be well. And then healthcare professionals' collaboration is very important. And then even the patient, from his presentation, even the patient has been empowered to check and confirm the authenticity. The ones mostly faked, the ones that are very expensive, they have panels on it, which you say you buy, you scratch, and instantly you will know whether it's fake. I don't know if you have done it before. They will tell you fake, don't use. And then there is a mobile number you will now forward to NAFDAC. And for our medical persons here, I don't know if you use the NAFDAC pharmacovigilance form, though it's called yellow form, but in our facility we have to make photocopies since we don't have the original. We do that. I think it's domiciled in many units in the hospital, so you make use of them. Most people are not involved in active pharmacovigilance, but passively we are doing it. Sometimes when we have to send to NAFDAC office through, so that will help us a lot. And we're talking about fake and counterfeit, increasing cost of treatment. Like what Dr. Teni say, if you know this is genuine, and you know if somebody is like doing a clinical trial, why don't you go for that particular one? Let the patient know from the beginning that this thing is expensive, instead of doing 4 trials before going back to the genuine one. And we are very happy in the state. The House of Assembly just passed the Drug Management Agency law. We hope by the time governor attend to it and is domicile in Benue. We had something like that 2007, Benue Essential Pharma, where we have manufacturers, both national and international, bring their drugs here. I remember you gave us some free drugs then, which we use in the hospital. We had Essential Pharma, which started very well, but along the way, Nigeria happened to it. We pray that by the time the governor will approve, sign it into law, and we bring DMA here, we source our drugs from manufacturers, I think we'll be able to control some of those things, though we cannot do it. It's an international epidemic, not only here, but at least we'll be able to reduce. Thank you very much.
Thank you very much, Pharmacist Maria. So we'll go panelists. So I don't know in what order. Okay, sir. Yes, sir.
Responses at this point to be entertained as regards the topic.
So there are one by Professor Keku, I think, which has mostly been answered by the Director of Pharmacy. We did a lot during my tenure at NAFDAC to try to eliminate counterfeit medicines in the country. But like I told you, the high volumes of counterfeit medicines in the system And with the entrance of former drug barons, it has become very difficult. Nigeria, with a population of 200 million, is an attractive site for counterfeiters to bring their medicines. Everybody wants to get to Nigeria because the population is huge and they have a good buying power compared to other countries. So you see counterfeit medicines, by the estimation of International Customs Organization, it's about $200 billion business annually. That was in 2010. Now it has gone to more than $413 billion, as was announced by the WHO in December last year. All this quantity of medicines are targeted at Nigeria. And you know, we have people here who want to make fast money. That's one of the fastest money. You're talking about $413 billion annually, which every criminal is trying to catch. So it's a big challenge. But what we did was we increased our surveillance. I even created a department whose job was just to go to pharmacy stores, buy medicines, and go back and test them to make sure that the medicine the consumer is buying is the same thing that we approved. We introduced cutting-edge technologies. I told you about the TrueScan, that we're just going around the country checking the medicines on the spot. Then we introduced the MAS, what is the mobile authentication service that enables the consumer themselves to scratch for most of the medicines that are often counterfeited, to scratch, text, and authenticate the medicines by themselves. So we have done a lot, and we have continued to do a lot. And I told you that with these interventions, by 2016, we were able to reduce the incidence of the counterfeit medicine to just less than 2%, which is a huge achievement. Compared, even countries like the US, Canada, and the European Union are about the same level with that, because up to 10%, because of buying medicines over the internet. They get some of those, they get counterfeits in their systems. So counterfeit is a very difficult thing to, and the producers have become more militarized. How many attempts were attempted at assassinating me during my tenure? I can't even tell you the number. So these people are ready to take you out if you stand in their way. It's a big fight that everybody, and we targeted public enlightenment campaigns, collaboration with traditional rulers, collaboration with religious rulers, religious authorities, collaboration with other sister agencies, even the hospitals, like the director said about pharmacovigilance, reporting back to NAFDAC if you even suspect any counterfeit medicine or the medicine has adverse reactions. So that is what the fight continues, and it's for everybody. Every Nigerian has a personal stake in what NAFDAC is doing to safeguard their health. Because whatever you put in your mouth is regulated by NAFDAC, and you should be able to report it. Counterfeit also thrives because of ignorance and the poverty. Somebody who is poor, if he sees a medicine that looks like a genuine one, he's ready to buy it, especially if you give him a huge discount, like I say. And the medicines are not even available. We have also started local manufacturing of these medicines. Like I told you, the case of oxytocin, that NAFDAC tried to get the United States Pharmacopoeia to collaborate with Juhe Pharmaceuticals because of the storage issue. Sometimes the medicines are not bad, but they are temolabile, and storage of the medicines is very difficult. Like oxytocin, when they tested it, 74% was bad. I think Dr. Andrea is here. She can tell you how frustrating a doctor is when you think you are administering oxytocin and it's not working. Then I moved to what Professor Okuma said. He wanted a situation where we could source these medicines for free for patients. These medicines are very expensive. Most of them are not even manufactured here in Nigeria. We have been trying to get Nigerian medicines to meet with WHO good manufacturing practices so that we can have good quality medicines supplied to Nigerians at accessible prices. When I came to NAFDAC, I assessed that more than 70% of medicines, essential medicines that are needed in this country, are imported from other countries. And I asked the question, I approached the National Security Advisor, I said, this is a national security issue. For example, if this drug cannot come from India or China or for some reason they cannot come, I didn't know a particular reason that might happen that this medicine could not come. But I envisioned that with 200 million Nigerians, what are we going to do with Nigerians if this medicine cannot come from? Then suddenly, I approached the presidency, the National Assembly, the National Security Advisor. Sometimes people will laugh at me and say, why are you? You are crazy. Why are you thinking that something will happen that medicine cannot come from outside? Then to our greatest shame, COVID happened. When COVID happened, everywhere was blocked. And to our greatest shame, chloroquine that most of us took when we were children, when our mothers used to first force us to take, was one of the drugs that was highly recommended for management of COVID. And guess what? Nigerians did not have a local manufacturer for chloroquine. More than 60 years, more than 70 years, this thing has been used in Nigeria effectively, and yet have a local manufacturer for chloroquine. This is when they woke up and created a 100 billion naira healthcare intervention fund. I advocated in those days for 200 billion naira to give loans at discount or maybe even interest-free rates to pharmaceutical manufacturers to stimulate the manufacture of local pharmaceuticals. If medicine is manufactured locally, you can just, if I hear that Juhe is manufacturing oxytocin that is not meeting the quality, I can just drive down to Oka and find out what is happening. But when you are importing these medicines, sometimes you don't have control over the medicines. And sometimes even the cost, you do not have much control over the cost of the medicine because you don't have any alternative. What I will do, though, is I'm very happy the CMD in setting up this one-stop hospital already saw in the future that the quality of medicine could be a problem and invited me to be involved. I am globally recognized as an anti-counterfeiting, product anti-counterfeiting expert. Even at the WHO, I was the vice chairman of the International Medical Products Anti-Counterfeiting Task Force, made up of 193 countries. And then later, when the WHO mechanism on spurious, substandard, falsely labeled, falsified counterfeit medicines was established in 2012, I was the pioneer chairman of that prestigious organization. So I'm known globally for counterfeit efforts. I have helped even companies that are not even medical or NAFDAC regulated. For example, the motorcycle industry approached me. They were faking their motorcycle brakes. And I helped some of them, advise them on what to do to reduce that. Talk less of medicine, which is my real area. So I will make every effort to contact my partners locally, some of them NGOs, because I know that many of them respect me. So if they see me acting, I'm doing the same thing, by the way, for the Buluri OSA program. You remember I launched that summit in let's say, last month. It was heavily successful, and now I'm trying to source medicines. We are partnering with the Bishop of Boko, the Boko Diocese. They are giving us space to set up our clinic for management of chronic ulcers, not just Buruli ulcer now, but chronic ulcers. And you heard the Commissioner for Health today say that because of that effort now, they have been invited to Australia to go and speak on this issue. So we do talk about the medical products too. And I will work very closely. I'm at the beck and call of the CMD. I told him, since he has seen the vision to invite me, I will make sure he's not disappointed. I will do my very best to source good quality medicine for this clinic.
Yes. I don't know if there's any panelist that wants to address any of the concerns. Yes, sir.
Thank you very much, Professor. Ask a question about those new cancers like esophagus, pancreas, and stomach. In fact, those cancers are called men of death because once they start, within 1 year, most patients die. So, and there are about 9 or 10 of them that if one has them, within 1 year the patient dies, no matter what you do. So it's a very big concern because it's coming to our country and it's even occurring in younger people. Instead of 70 and above, it's occurring in 40-year, 50-year-old people. But there are preventive measures, which was the thrust of your question. And the prevention hinges around diet, alcohol, smoking, and colonoscopy. For stomach, alcohol is known to be a major cause of cancer of the stomach. The same thing with pancreas. Alcohol is known to be a major cause or predisposing factor to cancer of the stomach. And unfortunately, our people drink. Our people drink alcohol. So it's preventable. So one should drink alcohol in moderation or abstain completely. Smoking, completely abstain. Because smoking is one of the worst drugs, and smoking is one of the causes of many cancers. And anywhere smoke touches, from the mouth to the anus, it can provoke cancer. So smoking should completely be abolished. Coming to the traditional diet, we should take a lot of vegetables and fruits and avoid too fatty diet. Diet that contains a lot of fat, we should avoid them. Then surgically, colonoscopy. You see, some of these cancers run in families, and so they are easy to prevent. Genetic. Cancer of the colon runs in families. In some families, you have 2 or 3 members having it. So from the age of 40, such family members are advised to do 6 months colonoscopy. Cancer of the pancreas runs in families. And one can check. Cancer of the esophagus. So those cancers, some of them have preventive measures. But certain other cancers don't have modifiable factors. They depend on maybe genetic factor, you can't do much about it. Age and sex, you can't change your sex, you can't change your age, it's a progression. But many of these other cancers, including the new ones, have modifiable factors that you can prevent. Alcohol, take a lot of vegetables, avoid smoking.
Thank you very much. We've heard from the experts. We know the predisposing factors or risk factors, and we know how we can prevent ourselves from having cancer. Do we have any other panelists? Yes.
Yes, thank you very much. I just want to add to what my chief says about cancers. You know, when we are young, they will tell you that the causes of cancers is unknown. That is the normal thing everybody knows. But now some few cancers have known causes, like the cancer of the cervix that we're talking about. The causative agent is a virus, human papilloma virus, most especially serotype 16 and 18. And people who have HIV and AIDS are usually with low immunity, and then they'll come down with the virus and then the cancers. And then liver cancers too. We have hepatitis B and C. And thank God, the cervical cancer, there is a vaccine for that. So if there's another way of preventing the cancer or its progression, the liver cancers will have hepatitis B and hepatitis C. You can know that those can be screened in the hospital, even in the teaching hospital. And then hepatitis C is even treatable, it's curable. When you have hepatitis C virus, it's curable. Unlike, so even some of the cancers can be curable. And then, like you rightly mentioned, we have so many chemicals that can cause cancers. And when you are old, as you are getting older, you are a potential candidate for cancer. So you tend to modify your lifestyle. Like you rightly mentioned, you take a lot of fruits, you take a lot of vegetables, you avoid fatty diets and all that. And cancer is genetic. That is why when somebody has, when you go to the hospital, they will ask you, is there any of your relative that has cancer of the breast? They will ask a woman. If your mother has it, it means that there's a tendency for another person to have it. So you tend to check regularly, so that, because there's a key that says early detection is key to management. But most of our people present late in the hospital at the advanced stage. So thank you very much. God bless you.
Thank you very much, Professor Joseph Anduwase. Yeah, we want to really appreciate our distinguished panelists. We appreciate Dr. Paul Botuegohi, who is a specialist, both known nationally and internationally, and an anti-counterfeit specialist too. Please, a round of applause for him, please. We also want to appreciate our pediatrician, consultant pediatrician, Professor Esegbe Edwin, the past Chief Medical Director of Bingham Teaching Hospital. Sir, thank you so much for being here. We also want to appreciate Professor Ngozi Andrea, consultant obstetrician and gynecologist and current head of department, obstetrics and gynecology department at the university and the teaching hospital. Thank you very much, ma'am. We also want to appreciate Professor Barnabas Eke, consultant general surgeon. Thank you so much for sharing your thoughts on this panel. Thank you, sir. And finally, we want to appreciate our former Honorable Commissioner for Health and Human Services, Professor Joseph Anduwasengbia. You know, if they don't do the diagnosis, we don't even know how we manage. So thank you so much, Prof, for your efforts in cancer management in Benue, North Central Nigeria, and the entire country and beyond. Thank you so much, sir. So, thank you for appreciating our panelists. Our panelists may also go to their seats if they so desire. And please, the audience, please let us give ourselves a very resounding round of applause. Thank you so, so much. When the history is being shared, your name will be marked in gold. Thank you so much.
Thank you very much for the wonderful presentation. Our panelists and resource persons who have shared their thoughts on a very vital issue of discussion. We appreciate you, even as they are going to retire to their seats. We appreciate you very profusely. They are going to have a shot, but of course, soon after the cutting of the cake, we will entertain a group photograph formally. May I inform you that this event is streaming live. Those are brothers from elsewhere in the country are watching, and of course in diaspora. And of course, this is quite monumental. Credit to the Capacity CMD and his team for the wonderful work that they are doing. We appreciate you. Distinguished invited guests, ladies and gentlemen, without wasting time, may I now create the indulgence of the Capacity CMD Benue State University Teaching Hospital to please rise, as well as his wife, to proceed and have the cutting of the cake, as well as the chairman CPC, CMAC, is also expected to join. The resource person, former NAFDAC boss, Dr. Paul Ohi, is also expected to join in the cutting of the cake, as well as the immediate past Commissioner for Health and Human Services. Please, let's do the needful, have the cutting of the cake done, and then thereafter we'll move to the other item, which is vote of thanks and closure, which is going to be chronicled by closing prayer. CMD Benue State University Teaching Hospital, Dr. Stephen Tengwa will come forward. His wife is already on the standby. Dr. Paul Ohi, former NAFDAC boss, as well as Dr. John Tol Agbide. They are expected to join in the cutting of the cake uniformly. Thank you. Let's rally around the CMD. CMD, please. You may stand in the middle. And then hold the knife. Stand in the middle. Hold the knife with your wife, supported by the former NAFDAC boss. Stretch your hands. Yes, very correct. So we are going to cut the cake after the acronym Benue State University Teaching Hospital must have been spelled. So please, cameramen, be very, very attentive. Give me a vibrating B, a resounding S, another vibrating U, another resounding T, and a powerful H. What have we spelled? BSU Teaching Hospital. A round of applause for them. Thank you very much. At this point, we may very quickly have group photograph. CMD, please do not retire to your seat yet. CMD will have a group photograph with the former NAFDAC boss, another top management of the University Teaching Hospital, as well as other professors that are here. The immediate past Honorable Commissioner for Health and Human Services, please, you may also need to partake in the group photograph. And then thereafter, we will entertain a vote of thanks. Please, photographers, do very quickly. Be very snappy, photographers. Group photograph. CMD in the middle. Chairman CPC by the side. CMD's wife by the side. And of course, our big daddies, former NAFDAC boss, former Honorable Commissioner for Health and Human Services, immediate past rather, as well as other top management staff. Let's form half a circle, so that the group photograph will be very unique. Let's form half a circle. You can spread yourself wide enough. Half a circle, very correct. Half a circle, you come, very correct. Come stand here. Another person should stand there. Half a circle. Thank you very much. Beautiful group photograph that is going to stand very historic and monumental, even as regards the importance of this event. We may put up some warm smiles even as we are going to have the group photograph. In London, we call this chin chin. And of course, that warm smile is there put across. Cheers, rather, in London, while in Nigeria, in chin chin. Thank you. Soon after the group photograph, please retire to your seats while I invite for his vote of thanks on behalf of the CMD and of course that of the top management of the Benue State University Teaching Hospital. May I invite Professor Agbi Tekola Michael, Acting Chairman, Medical Advisory Committee and Consultant Psychiatrist, Benue State University Teaching Hospital. Please come forward for your vote of thanks. Dr. Professor Agbi Tekola. Okay, he is already here. Okay, the Secretary of Head Committee, please come forward for a brief remarks before vote of thanks and then closure. Very quickly. That is just the urgent announcement that is, or rather adjustment that is made at this point in time. Secretary, over to you, ma'am.
Thank you very much. Good evening, the CMD. My name is Mary Teoka, PhD, Committee Secretary on Health and Human Services at Benue State House of Assembly. On behalf of the committee chairman, Honorable Pharmacist Thomas Dugeri, who is there in Abuja for a summit, he asked me to come and assure the CMD that the Committee on Health and Human Services and the entire House, Benue State House of Assembly, is willing to support you in all that you undertake. And once you come to the committee for any legislation, we are willing to support. So I should assure you that the House is with you in all that you are doing for the Benue people. Like there is a saying that health is wealth, so we are sure and we are happy with what you are doing, and we promise you our continuous support. Thank you. God bless you.
A round of applause for her. Just before I forget, somebody hinted me in the tete-a-tete that there is a message from the members of the Benue State House of Assembly, and I think that message concerns cash. Where is the person? If the person is available, please avail yourself of the message before vote of thanks. Okay. At this point, Professor Agbi Tekola, over to you for a vote of thanks. A round of applause for him, please.
Thank you all. I was in a gathering when someone was called upon to say the vote of thank. And the person stepped forward and just said, thank you all, and that was it. But before I say thank you all, let me first of all thank God for giving us the wisdom, for giving us the strength to come all the way far and near to grace this wonderful occasion. Next, I must appreciate our governor, Reverend Father Dr. Hysen Maria, for supporting this summit with a wonderful amount. I appreciate all the speakers. Appreciate the first lady of Benue State University Teaching Hospital, Chief Mrs. Hwandi. Next, I appreciate our capacity Chief Medical Director, the person of Dr. Stephen Tengwa Hwandi, who initiated this idea of making Benue State University Teaching Hospital a one-stop hospital. I can go on and on and on in calling names, but no, we have to leave this hall, isn't it? So I may not mention your name, but deep at the bottom of my heart, I send my appreciations to you. Thank you all, and God bless you as you go back to your various destinations.
Thank you very much, Professor Mike Tekola Agbi, for that wonderful vote of thanks. At this point, may I crave the indulgence of the high table and all who have come to grace this event to please rise as we close with a word of prayer, while I invite Professor Priscilla Dene Aka, Professor of Plastic Surgery, Benue State University Teaching Hospital, to please lead us in the closing prayer.
Thank you. Shall we give God the honor to stand up and pray? Father, we thank you for a successful scientific exhibition, endowment found for the establishment of a cancer center at BSUTH. We thank you for the wonderful vision you put in His Excellency, our Governor, Benue State, and the CMD, Dr. Hwandi, for which they have imparted onto all of us stakeholders. We thank you for the miracle donation by His Excellency and all our partners, both international and local. We thank you for the management of the teaching hospital, the staff, everyone, Benue citizens, our presenters, and the enormous information they've disseminated to us. Help us so that we use it right. We pray that, Father, you help our CMD so that he'll be focused to make this center a success for the benefit of Benue citizens and indeed the whole world. We pray that you help us all to do our parts. Let us all be part of this huge success. And we pray that, Father, you will raise more helpers for us, because we appreciate that even with these wonderful donations, we still need more to be able to maintain the facility. So we pray that you help us so that we'll be able to make a difference in the lives of every patient with cancer. Thank you, Father. In Jesus' name we pray. Amen.
Thank you very much. Please a round of applause unto God Almighty. When it comes to prayer, God Almighty takes the glory. But of course, we appreciate our mother, Professor Aka, for the wonderful closing prayer. Please, national anthem. Let's be upstanding. National anthem, please.
Nigerians all and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace our battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty Nigeria may be blessed.
Thank you very much. End of program. Finally, formally, before departure, on behalf of the capacity